Welcome to Multiple Sclerosis, Evidence-Based Update. Multiple sclerosis, commonly known as MS, remains one of the most common causes of non-traumatic neurological disability in young adults. It affects an estimated 2.8 million individuals worldwide and places a heavy burden on patients, families, and healthcare systems. Over the past several years, we've seen major advances in our understanding of MS pathobiology. We now have definitive evidence establishing Epstein-Barr virus, or EBV, as a dominant environmental risk factor. We've also come to recognize that progression independent of relapse activity, known as PIRA, drives the majority of long-term disability accumulation, even in patients traditionally classified as having relapsing disease. These insights have reshaped clinical approaches, prompting earlier initiation of high-efficacy disease-modifying therapies, expanded use of fluid and imaging biomarkers for individualized prognostication, and growing emphasis on detecting and treating the smoldering neuroinflammation that underlies progressive disability. For allied health professionals, including physical therapists, occupational therapists, nurses, and related clinicians, these advances carry direct implications for clinical practice. The expanding range of disease-modifying therapies demands familiarity with monitoring requirements, adverse effect profiles, and the ways treatment side effects may influence rehabilitation, participation, and functional outcomes. We now recognize that cognitive impairment, fatigue, depression, and autonomic dysfunction emerge early and interact bidirectionally with motor disability. That highlights the need for thorough, multidimensional assessment, using validated outcome measures with established, clinically meaningful change thresholds. Evidence-based rehabilitation interventions, including structured exercise prescription, cognitive rehabilitation, fatigue management programs, and spasticity management, continue to demonstrate efficacy across the disease continuum when appropriately adapted to disease stage and individual functional capacity. This course provides a thorough, evidence-based update on MS for the interdisciplinary clinical team. Drawing on current literature from 2022 through 2026, we'll examine disease foundations including epidemiology, pathophysiology, and classification, diagnostic criteria, and emerging biomarkers. The full spectrum of motor, sensory, cognitive, and invisible symptoms, standardized assessment tools and outcome measures, evidence-based rehabilitation interventions, disease-modifying therapies relevant to rehabilitation and nursing practice, and multidisciplinary care coordination models that optimize functional outcomes. Psychosocial considerations, including depression screening and treatment, caregiver support, health equity, and vocational rehabilitation, are integrated throughout. Upon completion, you'll be equipped to apply current evidence to deliver patient-centered, coordinated care for individuals with MS across the disease continuum. Upon completion of this course, you'll be able to accomplish the following learning objectives. First, identify the key genetic, environmental, and immunologic risk factors for multiple sclerosis. Second, describe the clinical features and disease trajectories that distinguish the major MS subtypes. Third, explain the role of progression independent of relapse activity, or PIRA, in MS disability accumulation. Fourth, recognize the major motor, sensory, cognitive, and invisible symptom clusters in multiple sclerosis. Fifth, list the standardized assessment tools recommended for evaluating key functional domains in MS. Sixth, define the evidence-based rehabilitation interventions used across MS disease stages. And seventh, state the roles of rehabilitation and nursing professionals in thorough MS care coordination. We begin with Module 1, Disease Foundations, covering epidemiology, pathophysiology, and classification. Let's start with epidemiology and risk factors. Multiple sclerosis is a chronic immune-mediated demyelinating and neurodegenerative disease of the central nervous system. Its development arises from the convergence of polygenic immune susceptibility and modifiable environmental exposures. Worldwide prevalence ranges from 5 to 300 per 100,000 people, with the highest rates observed in populations of Northern European descent and in temperate regions of North America and Europe. This follows a well-established latitude gradient that reflects both genetic ancestry and differential ultraviolet radiation exposure, affecting vitamin D synthesis. The female-to-male ratio is approximately 3:1, and this sex disparity has increased over recent decades, suggesting that environmental or lifestyle changes may disproportionately affect women. Typical age of onset falls between 20 and 40 years, with pediatric onset accounting for approximately 5% of cases. The strongest and most consistently replicated genetic risk factor is the HLA-DRB1*1501 allele, a human leukocyte antigen gene variant associated with immune regulation. It increases MS risk approximately 3-fold in heterozygotes and up to 6-fold in homozygotes. Genome-wide association studies have identified over 200 additional genetic variants, the majority involved in immune regulation, particularly antigen presentation and lymphocyte activation, though each non-HLA variant individually confers only a modest effect. Concordance rates in monozygotic twins are 20 to 30%, and the lifetime risk for first-degree relatives is 2 to 4%, compared with a baseline population risk of approximately 0.1%. That really shows how substantial, yet incomplete, the genetic contribution is. Among environmental factors, Epstein-Barr virus infection has emerged as the dominant infectious risk factor. A landmark prospective study in United States military personnel demonstrated that the risk of developing MS after EBV seroconversion was more than 30 times higher than in those who remained seronegative, making this one of the strongest environmental associations identified for any autoimmune disease. A history of infectious mononucleosis confers a 2 to 3-fold increased risk. Mechanistically, EBV latent proteins such as EBNA1, EBNA2, and LMP1 modulate B-cell biology and interact with MS-associated gene modules. Vitamin D deficiency is consistently associated with increased MS risk and is supported by Mendelian randomization studies demonstrating a causal relationship, which partially explains the observed latitude gradient. Cigarette smoking increases MS risk by approximately 40 to 50% and interacts synergistically with HLA-DRB1*1501, meaning that carriers of the genetic risk allele who also smoke face a compounded elevation in risk beyond what either factor alone would predict. Adolescent obesity, defined as body mass index above the 95th percentile at age 13, confers a 1.5 to 2-fold increased risk, also supported by Mendelian randomization evidence. Additional exposures with credible associations include low coffee consumption, shift work, and organic solvent exposure. The multifactorial nature of MS risk is well illustrated by how all these diverse genetic and environmental factors converge to produce inflammatory demyelinating lesions. Now let's look at the immunopathogenesis and neurodegeneration underlying multiple sclerosis. The adaptive immune system, particularly T and B lymphocytes, is central to MS pathogenesis. Both CD4-positive helper and CD8-positive cytotoxic T cells are found in MS lesions. CD4-positive T cells concentrate in perivascular cuffs, while CD8-positive T cells are more diffusely distributed within the parenchyma. Among CD4-positive T cells, T helper 1 cells produce interferon gamma and promote macrophage activation, while T helper 17 cells secrete interleukin-17 and granulocyte macrophage colony-stimulating factor. Both contribute to central nervous system tissue injury. The balance between these effector subsets and regulatory T cells is disrupted in MS, with impaired regulatory T cell function, allowing autoreactive T cells to persist. CD8-positive T cells are recognized as major effectors, capable of direct cytotoxicity against oligodendrocytes and neurons, with clonal expansion within the central nervous system, suggesting antigen-driven responses. B cells have emerged as key players in MS pathogenesis, as shown by the dramatic efficacy of anti-CD20 monoclonal antibodies in reducing disease activity. B cells contribute through antigen presentation to T cells, secretion of pro-inflammatory cytokines, and production of intrathecal immunoglobulins reflected by oligoclonal bands, which are distinct immunoglobulin bands indicating intrathecal antibody production in the cerebrospinal fluid of most MS patients. The formation of tertiary lymphoid structures containing B and T cells in the meninges, particularly in progressive MS, is associated with more severe cortical pathology and accelerated neurodegeneration. Innate immune cells are increasingly recognized as critical mediators of both acute and chronic central nervous system pathology. Microglia, the resident macrophages of the CNS, are activated early in lesion development. They contribute to myelin and axonal damage through release of pro-inflammatory cytokines, reactive oxygen and nitrogen species, and phagocytosis of myelin debris. Blood-derived macrophages infiltrate the CNS during active inflammation, and dendritic cells are implicated in priming and reactivation of autoreactive T cells within the CNS compartment. Other innate immune cells, including natural killer cells, mast cells, gamma-delta T cells, and mucosal-associated invariant T cells, have been identified in MS lesions and modulate disease activity through both pro-inflammatory and regulatory mechanisms. What's important to understand here is the dynamic interplay between adaptive and innate immunity. Adaptive immune cells initiate inflammatory cascades that recruit and activate innate immune cells, while innate immune activation through damage-associated molecular patterns promotes further adaptive immune responses. It's a feed-forward loop. The acute phase of demyelination is characterized by focal lesions or plaques, typically centered around small veins and distributed throughout both white and gray matter. These are populated by phagocytic macrophages and activated microglia that engulf myelin debris. Demyelination is mediated by direct T cell cytotoxicity, antibody and complement activation, and release of pro-inflammatory cytokines and reactive oxygen species, with oligodendrocyte apoptosis as a central event. Beyond acute relapses, Mississippi features a substantial component of chronic compartmentalized CNS inflammation termed smoldering or chronic active inflammation, driven by tissue-resident microglia and astrocytes, and less dependent on ongoing peripheral immune cell infiltration. Chronic active lesions are characterized by a rim of activated microglia and macrophages at the lesion edge with ongoing myelin degradation and axonal injury. Neurodegeneration in MS is multifactorial and closely linked to chronic demyelination. Demyelinated axons become vulnerable to metabolic stress due to loss of trophic support from oligodendrocytes and increased energy demands for maintaining action potential conduction. Mitochondrial dysfunction leads to energy deficits, impaired axonal transport, and increased susceptibility to oxidative damage. Ion channel redistribution on denuded axons, particularly increased sodium channel expression, further worsens metabolic stress. Glutamate excitotoxicity, mediated by excessive glutamate release and impaired astrocytic uptake, and oxidative stress from activated microglia contribute to neuronal injury. Synaptic loss, mediated by aberrant microglial pruning and complement activation, is increasingly recognized as a contributor to cognitive dysfunction. Multiple regulated cell death pathways are implicated in MS tissue injury, including apoptosis, necroptosis, pyroptosis, and ferroptosis, affecting oligodendrocytes, neurons, and glial cells. The release of damage-associated molecular patterns from dying cells perpetuates inflammation, creating a self-amplifying loop of tissue damage. Key dysregulated intracellular signaling pathways include NF-kappa B, which promotes pro-inflammatory cytokine expression in glial cells, and JAK-STAT, which drives pathogenic T-cell responses. Remyelination can occur, resulting in shadow plaques, which are partially remyelinated lesions with characteristically thinner myelin sheaths visible on histopathology. However, remyelination is often incomplete or fails entirely in chronic lesions. This happens because of depletion or dysfunction of oligodendrocyte precursor cells, inhibitory signals from reactive astrocytes, and aging-related epigenetic changes. The failure of remyelination in chronic lesions is a critical barrier to neurological recovery and a major target for emerging therapeutic strategies. Let's shift to MS subtypes and disease course. MS subtypes are defined by the temporal pattern of neurological dysfunction, the presence or absence of relapses, and the trajectory of disability accumulation. Clinically isolated syndrome, or CIS, refers to a first clinical episode of neurological dysfunction suggestive of demyelination, lasting at least 24 hours, in a patient who doesn't yet meet the full diagnostic criteria for MS. Patients with abnormal brain MRI have a substantially higher risk of conversion. 80% of patients with CIS and abnormal MRI progress to MS within 20 years, compared with 20% of those with normal MRI. Radiologically isolated syndrome, or RIS, refers to individuals with incidental MRI findings typical of MS in the absence of clinical symptoms, with 30 to 40% later meeting criteria for CIS or MS. Relapsing remitting MS, or RRMS, is the most common initial phenotype, accounting for approximately 85 to 90% of cases at onset. It's characterized by clearly defined relapses separated by periods of partial or complete remission. RRMS typically affects young adults with a mean age at onset of 30 years and a 3-to-1 female predominance. Secondary progressive MS, or SPMS, describes the phase following an initial relapsing remitting course, during which there's gradual irreversible accumulation of disability independent of relapses. The transition from RRMS to SPMS is often insidious and is typically assigned retrospectively, often years after onset, due to fluctuating symptoms and the absence of a definitive biomarker marking the transition. SPMS develops in approximately 50% of untreated patients with RRMS, though this rate has decreased to an estimated 15 to 20% over the past 30 years due to earlier diagnosis and disease-modifying therapy initiation. Primary progressive MS, or PPMS, is defined by progressive accumulation of neurological disability from disease onset without an initial relapsing remitting phase. It affects approximately 10 to 15% of patients, with a mean onset around age 40 and no female predominance. Pathologically, PPMS and SPMS share overlapping mechanisms of progression, including chronic active lesions, diffuse microglial activation, and neurodegeneration. The distinction is increasingly viewed as quantitative rather than qualitative. The rate of disability progression is similar in PPMS and SPMS after reaching an expanded disability status scale score of 4.0 or higher. The EDSS is a 0 to 10 clinician-rated scale of neurological disability, where higher scores indicate greater impairment. Recent revisions to MS phenotypic classification recommend using activity, meaning clinical relapses or new or enlarging MRI lesions, and progression, meaning gradual worsening of disability independent of relapses, as additional descriptors for all MS subtypes. This framework moves toward a more biologically grounded classification that acknowledges the continuum between relapsing and progressive disease. Here's where it gets really important. A critical conceptual advance is the recognition that progression independent of relapse activity, or PIRA, is the dominant mechanism of disability accumulation across all MS phenotypes. PIRA accounts for at least 50% of disability accrual events even in typical RRMS, with this proportion increasing with disease duration and age. In early RRMS cohorts, PIRA occurred in 27.6% of patients over 11.5 years of follow-up, compared to relapse-associated worsening in 17.8%. Long-term disability progression isn't predicted by relapse frequency. Instead, it's driven primarily by insidious PIRA occurring even during apparent clinical stability. Early PIRA, occurring within the first 5 years, is associated with a dramatically elevated risk of reaching EDSS 6.0, with patients who experience early PIRA more than 26 times as likely to reach that disability milestone, compared to those without early PIRA. PIRA overall is associated with an approximately 8-fold increased risk of reaching that same threshold, making it far and away the strongest predictor of long-term disability in MS. So what does that mean in practice? It means traditional relapse-focused surveillance may miss the dominant mechanism of disability progression. Cognitive impairment occurs early in MS, even in radiologically isolated syndrome and clinically isolated syndrome, with prevalence increasing across disease subtypes and correlating with disability progression and employment loss. Early cognitive impairment is clinically significant because it predicts future disability worsening, employment loss, and transition to progressive disease. The neuropsychological profile, affected domains, and staging of cognitive decline are discussed in detail in Module 3. Comorbidities are highly prevalent in MS and substantially worsen clinical outcomes. Psychiatric disorders, including depression and anxiety, affect 21 to 50% of people with MS, 2 to 3 times higher than the general population, and are associated with increased risk of relapse and disability worsening. Vascular comorbidities, including hyperlipidemia, hypertension, heart disease, and diabetes, accelerate disability accumulation. In one study, patients with one or more vascular comorbidities at diagnosis reached a point of needing ambulatory assistance roughly 6 years sooner than those without vascular comorbidities, with a median time to ambulatory assistance of 12.8 years compared to 18.8 years in the comorbidity-free group. That's a meaningful difference, and it was statistically significant, reflecting a moderately increased risk that held up after adjusting for other factors. Comorbidities exert effects throughout the disease course, from symptom onset through diagnosis to end of life, and are associated with higher relapse rates, greater physical and cognitive impairments, lower health-related quality of life, increased mortality, and increased healthcare use and costs. Despite high prevalence, psychiatric comorbidities remain underdiagnosed and undertreated, though treatment is associated with improved mood, quality of life, and potentially better disease-modifying therapy adherence. Symptom presentations shift across the disease course in characteristic patterns, with sensory symptoms, fatigue, and motor issues increasing in prevalence and severity from the prodromal period through progressive disease. The pathological substrate shifts from focal inflammatory lesions with blood-brain barrier disruption in early disease to diffuse pathology in normal-appearing white and grey matter with microglial activation and neurodegeneration in progressive disease, though these features overlap and differ in degree rather than in kind. Detailed symptom prevalence data and phenotype-specific patterns are presented in Module 3. Moving on to Module 2, Diagnosis, Prognosis, and Biomarkers. With the disease foundations in place, let's turn to diagnosis. The 2017 revised McDonald criteria remain the current gold standard for MS diagnosis, requiring demonstration of dissemination in space and dissemination in time of central nervous system lesions while excluding alternative diagnoses. Dissemination in space, or DIS, requires one or more T2 hyperintense lesions, which appear as bright areas on T2-weighted MRI sequences, indicating inflammation or demyelination, characteristic of MS in at least 2 of 4 CNS anatomical regions: paraventricular, cortical or juxtacortical, infratentorial or spinal cord. The 2017 revision allows both symptomatic and asymptomatic lesions to fulfill DIS criteria and includes cortical lesions alongside juxtacortical lesions. Dissemination in time can be shown by the simultaneous presence of gadolinium-enhancing lesions, which indicate active inflammation with blood-brain barrier breakdown, and non-enhancing lesions at any time, a new T2 hyperintense or gadolinium-enhancing lesion on follow-up MRI compared to baseline, or the presence of CSF-specific oligoclonal bands, which can substitute for demonstrating dissemination in time. This last point is a key 2017 revision. Oligoclonal bands indicate intrathecal antibody synthesis and are associated with higher risk of a second attack. In a prospective cohort of 251 patients with a first clinical attack, The 2017 criteria demonstrated moderate diagnostic accuracy for clinically definite MS diagnosis, correctly identifying roughly two-thirds of patients who went on to develop clinically definite MS, while also correctly ruling out about two-thirds of those who did not, representing acceptable but not definitive performance that reflects the criteria's emphasis on early diagnosis over perfect specificity. MRI is central to demonstrating both dissemination in space and time. Gadolinium-based contrast agents remain crucial for determining dissemination in time and informing differential diagnosis, as contrast-enhancing lesions predict future disease activity and disability progression. A consensus report by Magnums, CMSC, and NAMES recommends gadolinium use during diagnostic evaluation, but not for routine monitoring in relapse-free patients, since subclinical activity can be assessed through new T2 lesions. Clinicians should exercise caution when applying MRI criteria in patients older than 50 years or those with vascular risk factors, as periventricular lesions may represent small vessel disease rather than MS. Advanced imaging features show considerable promise for improving diagnostic specificity. The central vein sign, a small vein visible in the center of a white matter lesion characteristic of MS, helps distinguish MS from other conditions that produce white matter lesions. Paramagnetic rim lesions, which are chronic active lesions identified by a dark rim on susceptibility-weighted MRI reflecting iron-laden activated microglia at the lesion edge, are associated with disability progression and may serve as both diagnostic and prognostic markers. However, neither the central vein sign nor paramagnetic rim lesions have yet been incorporated into formal diagnostic criteria. Other promising advanced MRI techniques include myelin water imaging, quantitative susceptibility mapping, magnetization transfer imaging, and cortical lesion detection using double inversion recovery sequences at ultra-high field MRI. Leptomeningeal contrast enhancement, which reflects focal meningeal inflammation, associates with cortical atrophy and worse clinical outcomes, and may provide additional diagnostic information in ambiguous cases. Cerebrospinal fluid analysis provides critical supportive evidence when clinical and MRI findings are typical, though it isn't always necessary for diagnosis. The hallmark finding is CSF-specific oligoclonal bands, specifically the type 2 pattern, detected in up to 90% of MS patients using isoelectric focusing with immunoblotting, a high-sensitivity laboratory technique for separating and detecting immunoglobulin bands. Oligoclonal bands have high diagnostic value. In a large cohort study, CSF-specific oligoclonal bands were found in the vast majority of MS patients and were absent in the vast majority of non-MS patients, with the key clinical takeaway being that a negative result, meaning no oligoclonal bands detected, very reliably rules out MS, with a negative predictive value approaching 99%. However, when oligoclonal bands are present, they are not exclusive to MS, meaning additional clinical and imaging evidence is still needed to confirm the diagnosis. The high negative predictive value means that the absence of oligoclonal bands should prompt careful consideration of alternative diagnoses. Kappa-free light chains, which are fragments of immunoglobulin molecules produced during antibody synthesis that serve as markers of intrathecal immune activation, have emerged as an alternative biomarker with similar diagnostic accuracy, correctly identifying approximately 90% of both MS and non-MS patients. They offer notable advantages of being quantitative, rater-independent, and more cost-effective than traditional oligoclonal band testing. The 2026 Canadian Consensus Report recommends kappa-free light chains as equivalent to oligoclonal bands for demonstrating intrathecal immunoglobulin synthesis, representing a significant step towards standardizing CSF analysis practices across laboratories. The differential diagnosis of MS requires careful exclusion of alternative conditions, including other CNS inflammatory disorders, systemic inflammatory diseases, infections, hereditary disorders, and vascular diseases. Neuromyelitis optica spectrum disorder, or NMOSD, is distinguished from MS by the presence of serum aquaporin 4 immunoglobulin G antibodies, detected in approximately 80% of cases using cell-based assays that are highly specific, meaning a positive result almost certainly confirms NMOSD rather than MS, and characteristic clinical syndromes including optic neuritis and longitudinally extensive transverse myelitis extending 3 or more vertebral segments. Key differentiating features include the absence of Dawson's fingers on brain MRI, lower brain T2 lesion burden, and elevated astrocyte damage markers in CSF. MOG antibody-associated disease, or MOGAD, is a distinct autoimmune demyelinating disorder characterized by serum, myelin oligodendrocyte glycoprotein immunoglobulin G antibodies detected by cell-based assays. Patients with MOG antibodies should not be diagnosed with MS or NMOSD. Distinguishing clinical features in non-acute MOGAD include younger age at presentation, prominent optic nerve involvement, and absence of cortical lesions characteristic of MS. CSF granulocyte activation markers and complement factors are elevated in both MOGAD and NMOSD but not MS, providing high discriminatory power in diagnostically challenging cases. Both aquaporin 4 and MOG antibodies should be tested when an alternative inflammatory CNS disorder is suspected, as they rarely coexist. Small vessel disease is particularly relevant in older adults, where punctate subcortical white matter hyperintensities may be misinterpreted as MS lesions. MS lesions are typically ovoid, periventricular, involve the corpus callosum and spinal cord, and often surround a central vein. Vascular lesions, by contrast, are punctate, spare the corpus callosum and spinal cord, and may be associated with microbleeds. Other important mimics include adult-onset leukodystrophies, such as X-linked adrenoleukodystrophy and metachromatic leukodystrophy, which can present with progressive encephalopathy and symmetric confluent white matter changes, often with persistent enhancement beyond 3 months. Neurosarcoidosis, which may present with multiple cranial neuropathies, pachymeningeal thickening and pituitary or hypothalamic involvement, and CNS lymphoma, which can show heterogeneous lesions with necrotic cause, complete ring enhancement, and diffuse peripendymal involvement. Systematically excluding these mimics is essential, as misdiagnosis can lead to inappropriate immunomodulatory therapy and delayed treatment of the underlying condition. Accurate prognostication in MS has become increasingly important as the therapeutic options expand and treatment decisions carry long-term consequences. Several clinical features at baseline are consistently associated with higher risk of disability progression. Meta-analytic evidence demonstrates that male sex carries a modestly increased risk of progression, while smoking nearly doubles the risk, representing one of the strongest modifiable risk factors identified. Higher baseline disability on the EDSS significantly increases the likelihood of further worsening, and higher relapse frequency, though its effect is smaller, also contributes to progression risk. Importantly, early use of disease-modifying therapies is strongly protective, cutting the risk of progression by roughly 60%, which is among the most compelling arguments for early treatment initiation. MRI remains central to MS prognostication. Higher baseline volumes of both T1 hypointense lesions, sometimes called black holes, and T2 hyperintense lesions are each associated with a meaningfully increased risk of PIRA, with each carrying roughly a 50% or greater elevation in risk that is statistically reliable and clinically relevant. The presence of 10 or more brain lesions on MRI at baseline is associated with nearly a 3-fold increased risk of reaching EDSS 3.0, which represents the threshold of moderate disability. Spinal cord lesions and atrophy are particularly powerful predictors, independently forecasting clinical worsening, conversion to SPMS, and attainment of major disability milestones. In a 5-year multi-center study, the strongest baseline predictors of EDSS worsening were higher spinal cord lesion number, which showed the largest independent contribution, followed by lower normalized cortical volume and lower spinal cord cross-sectional area. Together, these MRI measures predicted subsequent disability worsening with strong accuracy, performing well enough to be considered clinically useful for identifying patients at highest risk. Infratentorial lesion location consistently predicts secondary progressive disease across all time points in long-term studies. Serum neurofilament light chain, or SNFL, is the most extensively validated fluid biomarker for predicting disease activity and long-term prognosis in MS. Reflecting neuroaxonal damage, SNFL concentrations correlate strongly with gadolinium-enhancing lesions on MRI, with elevations detectable up to 1 month before and persisting 2 to 3 months after lesion appearance. Higher SNFL levels are associated with a meaningfully increased probability of relapses, EDSS worsening, and evidence of disease activity in the following year, with each of these outcomes showing a statistically significant and clinically relevant elevation in risk as SNFL rises. Patients with SNFL levels above the 90th percentile of healthy controls show a 70 to 91% higher risk of relapse-associated disability progression. Here's what's encouraging. Elevated SNFL at disease onset does predict worse outcomes in untreated patients, but early treatment with high-efficacy disease-modifying therapies can counteract this poor prognosis. Clinical implementation is currently limited by high inter-individual variability, and age-adjusted percentile-based cutoffs and z-scores are being developed to address these limitations. Serum glial fibrillary acidic protein, or SGFAP, is a blood-based biomarker released by activated astrocytes that reflects glial injury and neuroinflammation. It's been validated as a prognostic biomarker specifically for PIRA and overall disability progression. Patients with worsening progressive MS show roughly 50% higher SGFAP levels compared with those with stable MS, even after accounting for differences in neurofilament levels. Meanwhile, the neurofilament difference disappears after accounting for SGFAP levels, suggesting SGFAP captures unique pathological processes related to progression that are not redundant with neurofilament measurements. The combined elevation of both biomarkers results in a 4 to 5-fold increased risk of confirmed disability worsening, and of PIRA specifically, representing a dramatically elevated risk profile that far exceeds what either biomarker predicts alone. In progressive MS specifically, each standard deviation increase in SGFAP is associated with approximately 10% higher confirmed disability worsening risk, with results mainly driven by SPMS participants, while higher SNFL levels predict worsening only in PPMS. Oligoclonal bands in cerebrospinal fluid carry prognostic as well as diagnostic significance. A large MS-based cohort study of 11,245 patients found that oligoclonal band-positive RRMS patients reached major disability milestones on the EDSS, including scores of 4, 6, and 7, significantly sooner than oligoclonal band-negative patients, with the risk increase ranging from moderately to substantially elevated across these milestones. A Swedish registry study demonstrated that oligoclonal band-positive patients had a roughly 30% increased risk of reaching EDSS 3.0 and nearly 40% increased risk of reaching EDSS 4.0, along with a 20% higher risk of conversion to SPMS, with all associations being statistically significant and clinically meaningful. Kappa-free light chains provide complementary prognostic information, with higher kappa-free light chain index predicting associations with PIRA, greater periventricular lesion burden, and cortical thinning. Patients with very high kappa-free light chain index values, specifically above 100, show nearly 4-fold increased risk of developing PIRA, representing one of the strongest CSF-based predictors of insidious disease progression. The number of oligoclonal bands may provide additional prognostic stratification, with higher band counts associated with more upper cervical lesions and greater T2 lesion burden. Meta-analysis data demonstrate that 87.7% of MS patients are oligoclonal band positive, and oligoclonal band positivity in CIS is a very strong predictor of conversion to MS, with positive patients roughly 10 times more likely to convert than those without oligoclonal bands. Emerging molecular biomarkers are expanding the prognostic toolkit beyond SNFL and oligoclonal bands. Glial fibrillary acidic protein and chitinase 3-like protein 1 are markers reflecting astrocytic activation and glial response that may provide complementary information about disease progression. Proteomic studies have identified multi-protein CSF panels that predict long-term disability severity with high accuracy, and multivariate models incorporating multiple serum proteins outperform single biomarkers for detecting disease activity. Atrophied T2 lesion volume, representing white matter lesions replaced by cerebrospinal fluid, has emerged as an independent predictor of disability progression and conversion to SPMS, capturing the cumulative destructive burden of the disease. Multimodal prognostic models integrating MRI measures, optical coherence tomography metrics, and serum biomarkers outperform single-modality approaches in predicting early disability accumulation. Despite these advances, a Cochrane systematic review concluded that no single multivariable prognostic model can currently be recommended for routine clinical use due to methodological limitations and lack of independent external validation. Emerging techniques under investigation include paramagnetic rim lesions on susceptibility-weighted imaging, which reflect ongoing chronic active inflammation and strongly associate with disability progression, myelin water imaging and quantitative susceptibility mapping, and PET imaging with myelin or microglia-specific ligands. Diagnostic delays remain a significant clinical concern, with over half of patients experiencing delays in some cohorts. A global survey of 107 countries, representing 82% of the world population, found that 83% reported at least one major barrier to early MS diagnosis. These barriers include lack of awareness of MS symptoms among the general public at 68%, lack of awareness among healthcare professionals at 59%, limited availability of professionals with diagnostic expertise at 44%, and neurologists lacking awareness or training in the 2017 McDonald criteria at 45%. Primary progressive MS is associated with longer diagnostic delays compared to relapsing remitting MS. Sensory symptoms at onset are independently associated with prolonged diagnostic delay, and initial consultation with non-neurologists, particularly ophthalmologists, results in significantly prolonged time to diagnosis. These delays carry measurable consequences. Longer diagnostic delays are associated with greater EDSS scores and higher SNFL levels at diagnosis. Patients diagnosed after more than one relapse show greater EDSS scores and more total and periventricular brain lesions compared to those diagnosed at first relapse. The concept of an MS prodrome has gained increasing recognition. Retrospective studies demonstrate that people with MS have increased healthcare use up to 10 years before diagnosis, with visits attributed to non-specific symptoms including gastrointestinal and urinary complaints, anxiety, depression, fatigue, insomnia, and pain. Serum neurofilament light concentrations can be elevated as early as 6 years before clinical disease onset, suggesting that subclinical neurodegeneration precedes the first clinical attack by a substantial margin. These findings highlight the importance of heightened clinical suspicion in young adults presenting with unexplained neurological symptoms and support ongoing efforts to develop screening strategies that could enable earlier diagnosis and intervention. Let's move to Module 3, Clinical Presentation, covering symptom burden across the disease continuum. Building on the disease mechanisms and diagnostic framework covered in the preceding modules, this module examines how MS manifests clinically across the symptom spectrum. Motor impairments are the most visible and functionally disabling symptom domain in multiple sclerosis. In a contemporary cohort study examining the full MS patient journey, motor symptoms were reported by 36.8% of patients at the time of diagnosis and by 62.6% at some point during the disease course. Motor and coordination symptoms are significantly more common in progressive forms than in relapsing remitting MS. At the time of survey, 50.7% of RRMS patients were asymptomatic for motor symptoms, whereas most patients with secondary progressive MS and primary progressive MS continued to experience persistent motor symptoms, imbalance, and fatigue. These findings really illustrate the phenotype-dependent nature of motor disability in MS and the progressive accumulation of impairment that defines the transition from relapsing to progressive disease. In PPMS, the most common clinical presentation is progressive spastic paraparesis, predominantly affecting the lower extremities, with gait disorders present in up to 88% and paresis in 38% of patients at initial presentation. Loss of motor and sphincter control tends to be more apparent than sensory manifestations, and exercise-induced fatigable weakness is a characteristic feature that distinguishes progressive motor dysfunction from relapse-related weakness. In SPMS, motor impairment becomes persistent and irreversible, with higher rates of unemployment and hospitalization compared to RRMS, reflecting the cumulative burden of neurodegeneration superimposed upon prior relapse-related injury. Gait dysfunction is a hallmark of MS-related disability and one of the most impactful functional consequences of the disease. Quantitative gait analysis reveals that MS patients exhibit distinct gait phenotypes, including sensory, pyramidal, and cerebellar, each with characteristic spatiotemporal features. Walking impairments are more than 20% greater in progressive MS compared to RRMS, even after adjusting for age, sex, height, and disease duration. Approximately 50% of patients require a walking aid within 15 years of diagnosis, and 29% eventually need a wheelchair. Spasticity, defined as a velocity-dependent increase in muscle tone resulting from upper motor neuron dysfunction, is a defining feature of PPMS and becomes increasingly prevalent with disease duration and the transition to SPMS. The progressive nature of gait deterioration across the disease continuum has important implications for rehabilitation planning, as interventions must be adapted to the patient's current functional level and anticipated disease trajectory. Sensory symptoms are among the earliest and most common manifestations of MS. Population-based data indicate that sensory disturbances are reported by 39 to 46% of patients before or at diagnosis, and by 76% over the disease course. These symptoms include paresthesias such as tingling and pins and needles sensations, dysesthesias or abnormal unpleasant sensations, numbness, and Lhermitte's sign, an electric shock-like sensation radiating down the spine upon neck flexion that is considered nearly pathognomonic, meaning highly characteristic and almost exclusively associated with demyelinating disease. Sensory disturbances reflect demyelination and axonal damage within the posterior columns, spinothalamic tracts, and dorsal root entry zones of the spinal cord, as well as lesions affecting brainstem sensory nuclei. In RRMS, sensory symptoms typically present acutely during relapses and may resolve partially or completely with remyelination and neural repair, often leaving residual deficits that accumulate with each subsequent episode. In progressive MS, sensory disturbances become chronic, widespread, and less responsive to treatment, reflecting cumulative demyelination and axonal loss. Don't underestimate the clinical impact of sensory dysfunction on functional performance. Impaired proprioception contributes significantly to gait instability and fall risk, while dysesthesias and neuropathic sensory symptoms are closely linked to chronic pain syndromes that further compound disability. Visual symptoms represent another hallmark of MS, with optic neuritis being the most common presenting syndrome. Population-based data indicate that 28% of patients have visual symptoms at disease onset, most frequently presenting as unilateral optic neuritis at 22%, followed by internuclear ophthalmoplegia at 16% and nystagmus at 13% during the disease course. Optic neuritis typically manifests as acute, painful, monocular vision loss with dyschromatopsia or impaired color vision, often accompanied by a relative afferent pupillary defect, an asymmetric pupillary response to light indicating unilateral optic nerve damage. Most cases of optic neuritis improve substantially, with 95% of affected patients regaining visual acuity of 20/40 or better, though subtle deficits in contrast, sensitivity, and color perception may persist. Visual symptoms are most prominent in RRMS, where they may occur as isolated relapses, while chronic visual impairment may result from cumulative damage to the optic pathway in progressive MS. Internuclear ophthalmoplegia, caused by lesions in the medial longitudinal fasciculus, produces characteristic diplopia and impaired adduction that may significantly affect reading, driving, and daily functional activities. Nystagmus, where the pendular or gaze evoked, is another common oculomotor finding that can be profoundly disabling and is often refractory to treatment. The clinical significance of sensory and visual symptoms extends beyond their direct functional impact. These symptoms frequently serve as initial presenting features that lead to diagnostic evaluation, and their pattern and evolution provide important prognostic information regarding the spatial distribution and temporal course of CNS demyelination. Clinicians should recognize that sensory symptoms, while sometimes dismissed as less disabling than motor impairments, substantially impact quality of life and functional independence. The combination of sensory loss, impaired proprioception, and visual dysfunction creates a compounding effect on balance and mobility that amplifies the impact of motor impairments, particularly in progressive disease stages, where compensatory strategies become increasingly limited. Let's now discuss the invisible symptoms of MS, beginning with cognitive dysfunction. Cognitive impairment affects approximately 34 to 65% of adults with MS, with prevalence varying by disease subtype, lowest in radiologically isolated syndrome and clinically isolated syndrome at 20 to 25%, intermediate in RRMS at 30 to 45%, and highest in SPMS and PPMS at 50 to 75%, and up to 80%. The most frequently affected domain is information processing speed, which is the rate at which an individual can take in, make sense of, and respond to incoming information, with impairment rates of 27 to 51%. This is followed by visual memory at 54 to 56%, verbal memory at 29 to 34%, executive function at 15 to 28%, and visuospatial processing at 22%. Basic language and attention span are rarely impaired, at approximately 10%. An event-based staging model proposed by Wojcik and colleagues suggests that cognitive domains become impaired in a temporal sequence: processing speed first, then visual learning, verbal learning, working memory and attention, and finally executive function. The stage of cognitive impairment correlates with greater neurological disability and increased probability of unemployment, showing the vocational and functional implications of cognitive decline. Isolated information processing speed impairment is a strong predictor of further cognitive decline, with 69% of patients progressing over 5 years. Recent evidence from modern diagnostic and treatment cohorts challenges the traditional speed-centric model, demonstrating that memory deficits, particularly working memory and episodic memory, are prominent even in early RRMS, while cognitive speed may remain relatively preserved. In SPMS, attention, executive function, and cognitive speed deficits become more prominent. Longitudinal studies show that over 10 years, the most severe declines occur in attention, verbal memory, and executive function, with cortical lesion load and formation predicting subsequent decline. Fatigue affects 60 to 90% of people with MS and is consistently rated as one of the most disabling symptoms across all disease subtypes. In the TONIC study, moderate to severe fatigue was present in approximately 56.5% of participants, with greater prevalence and severity in progressive subtypes. The cause of MS-related fatigue is multifactorial. Central mechanisms include neuroinflammation, demyelination, and altered cortico-striatal thalamocortical connectivity. Peripheral factors include deconditioning and muscle weakness, and secondary contributors include depression, sleep disturbance, and pain. Trajectory analyses from the TONIC study identify 4 distinct groups: 4.9% with low, stable fatigue, 28.9% with ongoing severe fatigue, and 66.3% distributed across 2 worsening trajectory groups. Depression is among the most strong predictors of fatigue severity, independent of physical disability. Pain is prevalent across the MS disease continuum, with rates of 36 to 40% for any pain and 26.8% for neuropathic pain in meta-analyses. Neuropathic pain is more common in women and demonstrates subtype-dependent variation, affecting 40.3% of patients with SPMS compared to 15.6% of those with PPMS. Pain syndromes in MS include dysesthesias, trigeminal neuralgia, and Lhermitte's sign. These are closely linked to fatigue and depression, with changes in these symptoms highly correlated over time. The interrelationship between pain, fatigue, and mood shows why thorough symptom assessment matters more than evaluating individual symptoms in isolation. Mood disorders are highly prevalent in MS. The lifetime prevalence of major depressive disorder ranges from 36 to 54%, compared to 16.2% in the general population, while anxiety disorders affect approximately 35.7%. The American Academy of Neurology guideline recommends routine screening for psychiatric disorders in all individuals with MS. Major depressive disorder is more frequent in progressive MS at 16.2%, compared to RRMS at 11.5%, with PPMS showing the strongest association. Depressive symptoms are the strongest single predictor of reduced health-related quality of life, irrespective of MS phenotype. In a prospective PPMS cohort, higher depression scores on the Hospital Anxiety and Depression Scale were strongly predictive of multi-domain disability progression at 1 and 2 years, with the likelihood of progression increasing substantially as depression severity rose, ranging from roughly a 3-fold increase at 1 year to more than a 9-fold increase at 2 years, depending on the domain assessed. These findings position depression not merely as a comorbid condition, but as an active contributor to disease progression and functional decline, with direct implications for early screening and intervention. Bowel and bladder dysfunction are among the most prevalent, yet under-recognized manifestations of MS. Bladder symptoms affect up to 91% and bowel symptoms up to 73% of patients over the disease course. Bladder dysfunction typically manifests as urgency, frequency, and incontinence resulting from detrusor overactivity, which involves involuntary bladder muscle contractions causing urgency, or detrusor sphincter dysynergia, which involves simultaneous contraction of the bladder and its outlet sphincter, impairing emptying. Bowel dysfunction most often presents as constipation and fecal incontinence. Moderate to severe bowel dysfunction is seen in 14% of MS patients overall, rising to 26 to 32% in those with higher disability levels and progressive disease forms. Nearly all patients report lower urinary tract symptoms after 10 years of disease. These symptoms are frequently under-recognized in clinical practice, with 42 to 47% of patients unaware of their connection to MS. Progressive MS subtypes are characterized by higher prevalence and severity of bowel and bladder dysfunction compared to RRMS. Beyond bladder and bowel dysfunction, autonomic disturbances in MS may also include sexual dysfunction, thermoregulatory impairment, cardiovascular autonomic dysfunction, and orthostatic intolerance, all of which can significantly affect rehabilitation, participation, and quality of life. Invisible symptoms rarely occur in isolation. In newly diagnosed MS, 21% of patients experience 2, 19% experience 3, and 17% experience all 4 of pain, fatigue, depression, and anxiety at some point in the first year following diagnosis. The accumulation of invisible symptoms is associated with more widespread cortical and deep gray matter atrophy, particularly in the thalamus, amygdala, basal ganglia, and cerebellum. Clustering analyses have identified 4 distinct MS patient phenotypes: cognitively preserved without mood or fatigue symptoms, cognitively preserved with fatigue, anxiety, and depression, cognitively impaired without mood or fatigue symptoms, and cognitively impaired with all symptoms combined. Cognitive impairment associates more strongly with deep gray matter atrophy, particularly hippocampus, amygdala, and thalamus, while fatigue, anxiety, and depression correlate more with cerebellar atrophy. The interaction between fatigue, cognitive dysfunction, and depression is one of the most complex and clinically significant symptom relationships in MS. These symptoms share overlapping neurobiological substrates, with abnormal corticothalamic basal ganglial and corticolimbic network connectivity underlying both fatigue and depression. Here's something worth noting. Self-reported cognitive complaints in MS patients correlate more strongly with fatigue, anxiety, and depression than with objective cognitive performance on neuropsychological testing. This dissociation tells us that perceived cognitive dysfunction often reflects the compounding burden of invisible symptoms rather than isolated cognitive impairment. And that has direct implications for clinical assessment. Subjective complaints should prompt evaluation of mood and fatigue in addition to formal cognitive testing. Fatigue, pain, and sleep disturbances demonstrate the strongest associations with overall quality of life, often exceeding the impact of visible motor symptoms. The interaction between invisible symptoms is bidirectional, with structural equation modeling demonstrating that these symptoms cluster together and predict worsening of each other over time. MS patients report an average of 5.07 plus or minus 2.18 symptoms simultaneously, with the collective symptom burden accounting for 13 to 21% of variance in community integration and mental health outcomes. Invisible symptoms may be severe even at mild disability levels, and they're more frequently reported in patient self-report surveys compared to clinician-reported registries, suggesting systematic underreporting when relying solely on physician documentation. This discrepancy emphasizes the importance of thorough patient-reported outcome measures and routine screening for invisible symptoms across all disability levels and disease subtypes. Healthcare professionals should recognize that invisible symptoms, including fatigue, pain, cognitive dysfunction, and mood disorders, may be the primary drivers of functional limitation and reduced quality of life, even when physical disability appears mild. Addressing these symptoms is within the scope of the interdisciplinary rehabilitation team. Let's move to Module 4, Standardized Assessment Tools and Outcome Measures. Now that we've explored the full spectrum of MS symptoms, the next step is quantifying these impairments with validated outcome measures. The timed 25-foot walk, or T25FW, is the most extensively validated objective measure of ambulatory function in MS. It serves as a core component of the Multiple Sclerosis Functional Composite, or MSFC, a standardized composite measure combining walking speed, hand dexterity, and cognitive processing speed. In large validation studies, the T25FW has demonstrated excellent measurement consistency, with repeated tests in the same patient producing virtually identical results, confirming that observed changes in clinical practice almost certainly reflect true change in the patient's walking ability rather than measurement error. Independent confirmation showed the measurement error to be approximately 1 second, meaning that changes beyond roughly 2.7 seconds or 36% can be confidently attributed to genuine functional change rather than normal test-to-test variability. The T25FW has strong construct and criterion validity, correlating highly with the Expanded Disability Status Scale and the Multiple Sclerosis Walking Scale 12. It separates MS patients from healthy controls with a large and clinically obvious performance gap of approximately 2.4 seconds, distinguishes patients with mild disability from those with moderate to severe disability with an even larger separation of approximately 5.4 seconds, and shows the greatest separation between relapsing remitting and progressive disease courses with a mean difference of 13.4 seconds, all of which represent large, clinically meaningful differences that are readily apparent in the testing environment. Changes in T25FW performance have been shown to precede changes in EDSS, supporting its predictive validity for disability progression. A 20% change in T25FW score is commonly proposed as clinically meaningful, though further validation across the full disability spectrum is warranted. The T25FW is quick to administer, requires minimal equipment, and is suitable for routine use in both rehabilitation and nursing settings across a wide range of disability levels. The 6-minute walk test, or 6MWT, is the gold standard for assessing walking endurance and fatigability in MS. The Academy of Neurologic Physical Therapy Clinical Practice Guideline reports that the 6MWT achieves excellent measurement consistency in MS populations, meeting the preferred reliability standard for clinical outcome measures. Spatiotemporal gait variables measured during the 6MWT also show good to excellent measurement consistency, meaning that the test reliably captures the same walking pattern each time it is administered under similar conditions. The 6MWT is more responsive than the T25FW in detecting clinically meaningful improvements after rehabilitation, particularly in patients with moderate to severe disability above EDSS-4, where the 6MWT demonstrates meaningfully better ability to detect real improvement compared to the T25FW, which performs closer to chance-level discrimination at higher disability levels. The minimal important change for the 6MWT, defined as the smallest change in score that patients or clinicians perceive as beneficial, is 21.6 meters from the patient perspective and 9.1 meters from the therapist perspective, while the minimal detectable change is approximately 88 meters, or 20%. The ecological validity of the 6MWT is strongest in patients with mild walking impairment at EDSS 2 to 3.5, where improvements transfer to increased everyday mobility, but is more limited in those with severe disability. The 6MWT requires a longer walkway and more time than the T25FW, which may limit its use in some nursing settings, but it remains feasible with assistive devices and is recommended as a core outcome measure in neurologic rehabilitation. The Dynamic Gait Index, or DGI, assesses dynamic balance, gait adaptability, and fall risk during various walking tasks. In MS, the DGI demonstrates excellent agreement between raters for total scores and good agreement when the same rater tests a patient on different occasions, confirming strong measurement reliability across clinical settings. Convergent validity is strong, with consistent and meaningful associations with established walking and balance measures. For full risk stratification, a DGI cutoff of 19 or below out of 24 is effective at identifying patients who are likely to fall, catching 87% of actual fallers, though it also flags some non-fallers, resulting in moderate specificity. The key clinical value is its high negative predictive value. A score above 19 reliably identifies patients at lower fall risk. The modified DGI provides an expanded scoring range with enhanced measurement precision. Cutoffs of 49 or below points distinguish fallers from non-fallers, and 29 or below identifies recurrent fallers. A clinically significant improvement on the modified DGI requires a change of 7 or more points, while the minimal detectable change is 5 points, meaning any improvement of 5 points or greater can be confidently attributed to real functional change. A clinically significant improvement on the standard DGI requires a 3-point increase. The DGI and modified DGI are practical for use in both rehabilitation and nursing settings for ambulatory MS patients with EDSS 1 to 6, requiring minimal equipment and providing actionable information for fall prevention and rehabilitation goal setting. Let's now discuss balance assessment. The Berg Balance Scale, or BBS, is one of the most widely used clinical balance measures in MS, assessing static and dynamic balance across 14 functional tasks scored on a 0 to 4 ordinal scale with a maximum of 56 points. The BBS demonstrates excellent agreement between raters and strong test-to-test consistency in MS populations, including those with cerebellar ataxia. However, psychometric analysis reveals that the BBS is mistargeted for ambulatory MS patients with mild disability. A significant proportion, 38.5%, achieve maximum scores, indicating a ceiling effect that limits sensitivity in detecting subtle balance impairments. The BBS is therefore more appropriate for patients with moderate to advanced walking disability. A prospective study established a BBS fall risk cutoff of 50.5 points, with adequate ability to distinguish between patients who do and do not go on to experience falls. The American Academy of Neurology recognizes the BBS as a valid measure of static balance, with a clinically significant improvement defined as a 4-point increment, a threshold that, when exceeded, reflects a meaningful change in functional balance capacity for the patient. The minimal important change for the BBS is 7 points, and the minimal detectable change is 6.2 points. A minimal detectable change of 3 points has also been reported in some studies, which is why disability level-specific interpretation matters. The Mini Balance Evaluation Systems Test, or Mini-BEST test, demonstrates superior measurement properties for ambulatory MS patients compared to the BBS. Test-retest reliability is good to excellent across the disability spectrum, with small measurement errors that support its use in tracking change over time. A large-scale synthesis of reliability studies across neurological populations confirms the Mini-BEST test has excellent internal consistency, meaning its items work together to measure a single coherent construct and excellent agreement, both between different raters and when the same rater tests a patient on separate occasions. Compared to the BBS, the Mini-BEST test has a markedly lower ceiling effect, with no patients hitting the maximum score compared to 38.5% for the BBS. It is also nearly twice as responsive to change following rehabilitation, and it requires a smaller change, just 4 points compared to 7 for the BBS, to be considered clinically meaningful. The Mini-BEST test assesses 4 balance control systems: anticipatory postural adjustments, reactive postural control, sensory orientation, and dynamic gait. This enables individualized rehabilitation planning that targets the specific balance subsystem driving impairment. The Mini-BEST test also outperforms the BBS in distinguishing patients who do and do not use mobility devices, and in identifying patients who experience falls, providing superior clinical decision-making value across both of these important outcomes. The bottom line for balance assessment: instrument selection should be guided by the patient's disability level and the clinical question being addressed. The Mini-BEST test is preferred for ambulatory patients with mild to moderate disability due to its superior responsiveness, absence of ceiling effects, and ability to identify specific balance subsystem deficits. The BBS is better suited for patients with moderate to advanced disability, or when full risk screening is the primary goal, using the established cutoff of 50.5. Integrating both measures across the disability spectrum, along with the DGI for dynamic gait assessment, provides thorough full risk stratification and rehabilitation planning data. Moving to upper extremity, cognitive, and fatigue measures. The 9-hole peg test, or 9-HPT, is the gold standard for assessing manual dexterity in MS and a core component of the MSFC. It demonstrates excellent test-retest consistency, strong construct validity that discriminates between healthy controls and MS patients at varying disability levels, and moderate to strong correlations with patient-reported manual ability. A 20% change in 9-HPT score is commonly used as the threshold for clinically meaningful worsening, and the 9-HPT is better at correctly identifying patients who go on to experience sustained worsening compared to both the EDSS and T25FW, making it particularly valuable for tracking upper extremity decline over time. The 9-HPT is brief, under 5 minutes for both hands, requires minimal equipment, and is suitable for routine use in all clinical settings. The Action Research Arm Test, or ARAT, provides a more detailed assessment of upper limb function, evaluating grasp, grip, pinch, and gross motor tasks. It demonstrates very high agreement between raters and strong test-retest consistency in multicenter studies, including MS patients. The ARAT correlates well with the 9-HPT and other upper limb measures, and instrumented versions using wearable sensors can detect subtle impairments not captured by standard scoring. The ARAT takes 10 to 15 minutes to administer and requires standardized objects, which may limit feasibility in some nursing settings. Abbreviated 15-item versions maintain reliability while reducing administration burden. Current evidence recommends combining the 9-HPT and ARAT to capture the full spectrum of upper limb impairment, activity limitation, and participation restriction. The Symbol Digit Modalities Test, or SDMT, is the most sensitive and reliable single cognitive screening tool for MS, with strong ability to distinguish MS patients from healthy controls and consistent test-retest reliability across studies. The National MS Society, the Consortium of Multiple Sclerosis Centers, and the International Multiple Sclerosis Cognition Society recommend the SDMT as the minimum bedside cognitive screening tool, with baseline testing soon after diagnosis and annual reassessment. Cut scores of 44 and 38 provide clinical decision points. A score of 44 identifies patients with probable cognitive impairment using a more inclusive threshold, while a score of 38 identifies those with more definitive impairment using a stricter threshold, and both cutoffs demonstrate excellent sensitivity and specificity for clinical use. A 4-point change is considered clinically important based on employment anchors, while a change of 8 or more points represents statistically reliable decline at the 80% confidence level using reliable change methodology. The SDMT requires approximately 5 minutes, uses the oral response format to avoid confounding by upper extremity weakness, and is feasible for routine administration by non-specialist staff in all clinical settings. The Brief International Cognitive Assessment for Multiple Sclerosis, or BICAMS, is a 15-minute battery comprising the SDMT, the California Verbal Learning Test 2, and the Brief Visuospatial Memory Test Revised. A systematic review and meta-analysis of 26 international validation studies confirmed that the SDMT component shows the largest performance gap between MS patients and healthy controls, representing a large and clinically obvious difference in information processing speed. The verbal and visual memory components each show a moderate but still meaningful performance gap, confirming that cognitive impairment in MS extends beyond processing speed alone. Test-retest consistency is strong across all 3 components, with the SDMT showing the most stable scores on repeated testing. BICAMS detects cognitive impairment in over half of MS patients and is responsive to changes during relapses. In time-restricted settings, the SDMT combined with the Brief Visuospatial Memory Test, revised at 10 minutes, captures nearly all cases of cognitive impairment detected by the full battery, with 92.7% sensitivity and strong agreement with the complete 3-test panel. Cut scores for impairment on the California Verbal Learning Test 2 are 39 at the more inclusive threshold and 35 at the stricter threshold, and for the Brief Visuospatial Memory Test, revised are 17 and 16 at those same respective thresholds. BICAMS is intended for cognitive monitoring and screening and isn't a substitute for full neuropsychological assessment when detailed evaluation is clinically indicated. The Modified Fatigue Impact Scale, or MFIS, is a 21-item, multidimensional patient-reported outcome measure assessing the physical, cognitive, and psychosocial impact of fatigue, with total scores ranging from 0 to 84. The physical subscale contains 9 items, the cognitive subscale contains 10 items, and the psychosocial subscale contains 2 items. The MFIS demonstrates excellent test-retest consistency and internal consistency across multiple language versions, meaning the items reliably measure the same construct and produce stable scores over time in the absence of true clinical change. It has strong convergent validity with the fatigue severity scale, strong discriminant validity with the ability to correctly classify approximately 80 to 90% of fatigued and non-fatigued MS patients using a cutoff of 35.5, and demonstrated known groups validity, meaning the ability of a measure to distinguish between groups known to differ on the construct being measured, distinguishing fatigued from non-fatigued MS patients at a cutoff of 38. The minimal clinically important difference for the MFIS is most reliably set at a reduction of 10 points on the total score, with reductions between 5 and 10 points also considered meaningful in some contexts. The minimal detectable change is approximately 8 to 10 points. Recent trials, including the Combo MS trial, demonstrate that a 10-point or greater reduction represents clinically meaningful improvement, with 65 to 70% of patients achieving this threshold with effective interventions. Compared to the fatigue severity scale, the MFIS offers greater measurement precision across the fatigue spectrum, lower ceiling effects, and broader assessment of cognitive and psychosocial domains, making it preferable for thorough evaluation and intervention studies. The MFIS is recommended as a core outcome measure for fatigue in exercise and rehabilitation studies by an international consensus group and is suitable for routine use in both rehabilitation and nursing settings. Now let's discuss spasticity and quality of life instruments. The Modified Ashworth Scale, or MAS, is the most widely used clinical tool for assessing spasticity in MS. A systematic review and meta-analysis of 33 studies with more than 1,000 participants found that the MAS demonstrates satisfactory but variable agreement between raters, with better consistency when used for the upper extremities than the lower extremities. This variability means that clinicians should be cautious about comparing MAS scores between different examiners, particularly for lower extremity assessments, and should ideally have the same clinician perform serial assessments on a given patient. The MAS measures resistance to passive movement, but doesn't account for the velocity-dependent nature of spasticity, can't distinguish between neural and non-neural contributors to resistance, and is best considered an ordinal measure of hypertonia rather than true spasticity. The ambiguity between the 1 and 1+ grades further limits its interpretability. Despite these limitations, the MAS remains foundational for routine clinical monitoring due to its simplicity and broad inclusion in major guidelines. The Tardio scale addresses key shortcomings of the MS by assessing resistance at both slow and fast velocities and recording the angle of reflex onset and full passive range of motion, thereby more closely adhering to the classic definition of spasticity as a velocity-dependent phenomenon. The American Academy of Physical Medicine and Rehabilitation 2024 consensus statement recommends the Tardio scale as the only clinician-reported outcome recommended for assessing spasticity, while Ashworth-derived scales were excluded due to their focus on muscle tone rather than true spasticity. However, the Tardio scale is more time-consuming and less frequently used in routine practice, and its reliability evidence, while promising, is less extensive than that for the MAS. Patient-reported outcome measures for spasticity complement clinician-rated scales and capture the subjective experience of spasticity's impact on daily function. The Multiple Sclerosis Spasticity. Scale 88 is a thorough, disease-specific measure with 8 subscales, demonstrating high internal consistency, strong test-retest reliability, and sensitivity to change following interventions. The numeric rating scale for spasticity is a single-item 0 to 10 scale with good test-retest reliability and established clinically meaningful change thresholds of approximately 18% for minimal clinically important difference and 30% for clinically important difference. Current guidelines recommend integrating patient-reported outcomes with clinician-rated and functional measures for thorough spasticity assessment. Multiple disease-specific and generic quality of life instruments have been validated for adults with MS. The Multiple Sclerosis Impact. Scale 29 or MSIS 29 captures both physical impact through 20 items and psychological impact through 9 items. It demonstrates excellent internal consistency, high test-retest reliability, and superior responsiveness to clinical change, performing as the most responsive physical quality of life measure in both rehabilitation and relapse settings, with strong ability to detect meaningful differences across treatment conditions. Established minimal important change scores for the MSIS 29 are 9.1 for the physical subscale, 5.5 for the psychological subscale, and 14.1 for the total score. The MSQoL 54 and its shortened version, the MSQoL 29, demonstrates strong psychometric properties, with the MSQoL 29 achieving high test-retest reliability and completion time of approximately 7 minutes, making it practical for nursing settings. The NeuroQoL short forms demonstrate high internal consistency, acceptable test-retest reliability, and strong concurrent and known groups validity, offering a computer-adaptive testing approach that reduces assessment burden while maintaining precision. Generic instruments such as the EQ5D5L are valuable for health economic evaluations and cross-disease comparisons, but are consistently less responsive to MS-specific changes than disease-specific measures. Direct head-to-head comparisons demonstrate that disease-specific instruments reduce required clinical trial sample sizes by more than half compared to generic alternatives. Selection of assessment instruments should be guided by clinical context, patient disability level, and the specific domains of interest. For mildly disabled patients at EDSS 4 or below, clinicians should use the mini-best test rather than the BBS, which shows ceiling effects in this population, and the 6MWT shows better responsiveness than the T25FW. For moderately to severely disabled patients above EDSS 4, the BBS is appropriate and the T25FW remains a reliable minimum ambulatory assessment. Cognitive screening should include the SDMT at baseline and annually, with the full BICAMS battery when time permits. Fatigue should be assessed with the MFIS, using a cutoff of 38 for high impact and a 10-point or greater change as clinically meaningful. Spasticity assessment should integrate the MAS for rapid screening with the Numeric Rating Scale for Spasticity, or MSS88 for patient-reported impact, and the TARDU scale when velocity-dependent measurement is needed. For quality of life, disease-specific instruments such as the MSIS-29 are preferred for clinical monitoring, with generic instruments used in parallel for health economic evaluations. Let's turn to Module 5, Rehabilitation Interventions, covering evidence and practice. The learning objective for this module is to define the evidence-based rehabilitation interventions, including exercise prescription, occupational therapy, cognitive rehabilitation, and fatigue management strategies, and their adaptation across MS disease stages and functional levels. Now that we've established how to measure MS-related impairments, let's look at the evidence-based interventions that address them. The National MS Society, in collaboration with the Consortium of Multiple Sclerosis Centers, recommends that all individuals with multiple sclerosis engage in at least 150 minutes per week of exercise and/or lifestyle physical activity, with gradual progression based on abilities, preferences, and safety. Early evaluation by a healthcare professional experienced in MS, such as a physical therapist, occupational therapist, or exercise scientist, is advised to establish an individualized exercise plan, and as disability increases, specialist referral becomes essential. Exercise and Sports Science Australia specifically endorses moderate-intensity aerobic and resistance training performed 2 to 3 times per week for people with mild to moderate MS at EDSS 6.5 or below, supplemented by balance exercises to prevent falls. Here's something I want to stress. Exercise is safe for people with MS. A meta-analysis demonstrated no higher risk of clinical relapse, adverse events, or serious adverse events compared to controls, with all comparisons showing essentially equivalent safety profiles between exercising and non-exercising groups. There are no absolute contraindications to exercise in MS, and healthcare providers should endorse and promote its benefits for every person with the disease. Aerobic training consistently improves cardiorespiratory fitness, gait speed, walking endurance, balance, and fatigue. A thorough meta-analysis found that aerobic training produced a small but significant improvement in cardiorespiratory fitness, a large improvement in timed up-and-go performance, a large improvement in gait speed, a moderate improvement in walking endurance, and a moderate reduction in fatigue perception, all of which were statistically significant and clinically relevant. Subgroup analyses indicated that continuous aerobic training and walking-based modalities were particularly effective for optimizing gait speed. A separate meta-analysis confirmed that exercise significantly improved Berg Balance Scale scores by an average of 3.77 points, approaching the clinically meaningful threshold. Exercise also improved timed up-and-go times by 1.33 seconds, increased 6-minute walk test distance by an average of 25.56 meters, which exceeds the 21.6-meter patient-perceived minimal important change threshold. Additionally, exercise reduced fatigue and improved MS quality of life. 54 scores by an average of 11.80 points. Aerobic exercise was the most effective intervention type for quality of life. Resistance training is equally effective as aerobic training for improving lower extremity physical function and perceived fatigue. Both modalities significantly improve short walk test performance and long walk test performance and reduce perceived fatigue with no clear superiority of one over the other. A network meta-analysis further supports resistance training as the most effective intervention for fatigue reduction, demonstrating a large treatment effect, especially in women and during programs lasting more than 8 weeks. Practical exercise prescription typically involves moderate-intensity aerobic and resistance training 2 to 3 times per week, with individualization for comorbidities, symptom fluctuations, fatigue, and heat sensitivity. Balance and gait training are critical components of fall prevention and mobility optimization. The American Academy of Neurology guideline reports that weekly home or outpatient physical therapy for 8 weeks probably improves balance, disability, and gait in ambulatory patients able to walk at least 5 meters, but probably is ineffective for improving upper extremity dexterity. Motor and sensory balance training over 3 weeks is possibly effective for improving static and dynamic balance across all MS subtypes. Gait, balance, and functional training interventions yield the greatest improvement in balance outcomes, showing a large treatment effect that exceeds other intervention types. A moderate positive correlation exists between program volume and treatment effect, suggesting that higher intensity programs may be more effective. Falls are highly prevalent in MS, with fall rates of 56% and 29 to 45% of individuals experiencing recurrent falls within 6 months. Progressive disease course confers a 2-fold increased fall risk compared to relapsing remitting MS. Balance exercises should supplement resistance and aerobic training, incorporating static and dynamic challenges with highly challenging activities to maximize effectiveness. Heat sensitivity affects a substantial proportion of people with MS and can cause transient symptom worsening through impaired conduction in demyelinated axons. This is known as Uthoff phenomenon, a transient worsening of neurological symptoms caused by elevated body temperature, which slows nerve conduction in demyelinated fibers. Resistance training is better tolerated than endurance exercise in heat-sensitive individuals, as endurance exercise produces greater core temperature elevation. Clinical modifications include exercising in air-conditioned facilities, using cooling vests or fans, scheduling sessions during cooler times of day, and ensuring adequate hydration. Exercise-induced fatigue is managed through appropriate prescription. Meeting physical activity guidelines of at least 150 minutes per week significantly reduces fatigue severity, with aerobic training showing the largest within-group reductions in fatigue, severity of 18.8%, and fatigue impact of 35.3%. Exercise prescription parameters for mild to moderate disability at EDSS 6.5 or below include aerobic training at moderate intensity, 40 to 70% of heart rate reserve, for 10 to 30 minutes, 2 to 3 days per week. Resistance training at 8 to 15 repetitions with moderate load, progressing from 30 to 50% up to 50 to 80% of 1 repetition maximum, in 1 to 3 sets per major muscle group, and supplementary balance training at least 2 to 3 days per week. For patients with higher disability at EDSS 7 or above, rehabilitation intensity is necessarily lower, often requiring assistance from trained staff with goals focused on preventing complications, maintaining joint range of motion, optimizing seating and positioning, and supporting residual function. Task-specific occupational therapy targeting activities of daily living and upper extremity function is supported by low to moderate certainty evidence. The 2026 Cochrane review of 20 studies with 1,628 participants found that occupational therapy may provide a small benefit for daily functioning compared to active control, a moderate benefit compared to no intervention, and a large but very uncertain effect compared to usual care. Occupational therapy may also offer a small benefit for mental health-related quality of life versus active control, with some persistence in the medium term. The American Occupational Therapy Association practice guidelines identify strong evidence for coaching interventions, addressing physical activity routines, and moderate evidence for medication management, with task-specific training supporting work participation. Interventions are generally delivered over 6 to 12 weeks, involving 1 to 3 sessions per week, with adaptation based on EDSS and individual functional goals. Fatigue affects up to 90% of people with MS and is often cited as the most disabling symptom. Cognitive behavioral therapy, or CBT, is a first-line non-pharmacologic intervention for MS-related fatigue. The COMBO MS trial, a large statistician-blinded parallel-arm randomized controlled trial, demonstrated that telephone-based CBT, modafinil, and their combination each produced clinically meaningful reductions in fatigue impact, with more than 60% of participants in each group achieving clinically meaningful improvement, defined as a 10-point or greater reduction on the MFIS. CBT effects were maintained at 24-week follow-up, and individual face-to-face CBT interventions have been shown to be more effective than group-based formats. Energy conservation education demonstrates modest but significant reductions in fatigue severity and fatigue impact. Combined interventions integrating behavioral and exercise components yield the largest treatment effects for fatigue reduction. Modafinil is a reasonable pharmacologic adjunct for patients with good sleep hygiene, but may worsen sleep quality in those with poor sleep hygiene, making CBT preferable in such cases. Web-based CBT and multi-component exercise interventions are identified as potentially cost-efficient therapies due to reduced healthcare professional time. The American Academy of Physical Medicine and Rehabilitation Consensus Guidance identifies passive and active stretching, positional stretching including static and dynamic bracing and serial casting, strength and endurance therapy, motor learning approaches, and electrical stimulation therapies as key non-pharmacologic techniques for spasticity management. However, recent evidence challenges assumptions about stretching superiority. A fully powered randomized controlled trial comparing guideline-based spasticity education with stretching exercises versus education with range of motion exercises found no significant difference in spasticity impact between groups at 1 and 6 months, with both groups experiencing improvements. This suggests that any form of structured movement may confer benefit. Exercise therapy, particularly robot-assisted gait training and outpatient exercise programs, has the best quality evidence for beneficial effects on self-perceived spasticity and muscle tone. A multicenter randomized controlled trial demonstrated that 4-week multidisciplinary inpatient rehabilitation led to a clinically meaningful 2.0-point reduction on the numeric rating scale for spasticity, exceeding the approximately 18% change threshold considered minimally clinically important for this measure, with benefits sustained through long-term management using a software application. Low-level evidence also supports physical activity programs and repetitive magnetic stimulation for spasticity improvement. Beyond physical symptom management, rehabilitation must address cognitive dysfunction, which frequently co-occurs with spasticity and other motor symptoms across the disease continuum. Cognitive impairment affects 40 to 80% of adults with MS and is a major driver of disability and unemployment. Computerized cognitive training produces moderate improvements in overall cognitive function, with small to moderate effects in attention and processing speed, executive function, and verbal and visuospatial memory. The modified story memory technique provides Class 1 evidence, the highest level of clinical evidence derived from well-designed randomized controlled trials for efficacy, with moderate to large improvements in verbal memory on the California Verbal Learning Test and self-reported everyday functioning persisting up to 6 months post-treatment. The COGEX trial, a landmark multinational sham-controlled study in progressive MS, found that approximately 2/3 of participants showed clinically significant improvement in processing speed after 12 weeks of cognitive rehabilitation, with nearly 50% maintaining improvement at 6 months. A Cochrane review of 44 randomized controlled trials with 2,714 participants found small but significant improvements in subjective memory, verbal memory, information processing, and quality of life at intermediate follow-up of 1 to 6 months. Typical regimens involve 2 to 3 sessions per week for 8 to 12 weeks, with each session lasting 45 to 60 minutes, and booster sessions may be necessary to sustain gains. Younger patients with higher education and mild to moderate cognitive difficulties are most likely to benefit from group-based cognitive rehabilitation, while patients with progressive MS and lower cognitive reserve may require more frequent individualized sessions with greater emphasis on compensatory strategies. Several emerging rehabilitation modalities show promise for MS, though most carry low to moderate certainty evidence. Robot-assisted gait training demonstrates moderate short-term benefits for walking velocity, endurance, balance, and fatigue, particularly using grounded exoskeletons. Robot-assisted gait training appears most beneficial for patients with severe disability above EDSS-6, where it leads to better functional outcomes than conventional therapy, and can preserve gait speed in those with moderate to severe impairments. Virtual reality rehabilitation shows moderate certainty evidence for improving balance and postural control compared to conventional therapy, with Berg Balance Scale improvements of 2.39 points approaching the 3-point clinically important difference. Virtual reality demonstrates moderate effects on fatigue, quality of life, and participation across disability levels. Aquatic therapy provides good to very good evidence for improving functional capacity, balance, and fatigue. 8-week programs of 3 sessions per week at 45 to 60 minutes significantly improve the 6-minute walk test, Berg Balance Scale, and Modified Fatigue Impact Scale. Transcranial direct current stimulation demonstrates moderate to strong treatment effects for fatigue, pain, mood disturbance, and cognitive processing speed, though sample sizes remain small and results are inconsistent across studies. Dual-task training shows significant benefits for dual-task walking performance, with meta-analysis demonstrating improvements in timed up and go and Berg Balance Scale compared to single mobility training, and is particularly effective when using structured cognitive motor exercises over 8 weeks. Mind-body interventions including yoga, tai chi, qigong, and mindfulness-based stress reduction demonstrate large effects for reducing stress, depression, and anxiety, with moderate overall effects on well-being that persist at follow-up. Mind-body movement interventions significantly improve balance and may reduce pain and depression, with high feasibility demonstrated through attendance rates of 92% and low attrition of 5%. These interventions appear particularly beneficial for patients with clinically relevant baseline depression, fatigue, or anxiety. Rehabilitation intensity and goals must be adapted across the disease continuum. In relapsing remitting MS, rehabilitation goals focus on restoration of function following relapses, prevention of secondary complications, and maintenance of physical activity, with higher intensity interventions prioritized post-relapse to maximize neuroplasticity. In progressive MS, the focus shifts toward adaptation, compensation, and preservation of function, as restoration is less often achievable due to insidious disability accumulation. The International Progressive MS Alliance identifies restorative and rehabilitation approaches as the mainstay of management in progressive MS. Telerehabilitation and on-site rehabilitation demonstrate comparable efficacy in improving quality of life, fatigue, balance, and cognition, expanding access for patients with mobility limitations or geographic barriers. Key implementation barriers include disease heterogeneity, requiring highly individualized plans, logistical challenges, and insurance coverage variability. Facilitators include multidisciplinary team approaches, individualized goal-oriented planning using the International Classification of Functioning framework, and advances in rehabilitation technology, including telerehabilitation, virtual reality, and digital self-management applications. Let's move to Module 6, Disease-Modifying Therapies and Pharmacologic Management. The learning objective for this module is to state the roles and responsibilities of rehabilitation and nursing professionals in disease-modifying therapy monitoring, adverse event recognition, multidisciplinary care coordination, and patient education for self-management. While rehabilitation interventions directly address functional impairments, disease-modifying therapies target the underlying disease process itself. The pharmacologic management of multiple sclerosis centers on disease-modifying therapies, or DMTs, that reduce relapse rates, delay disability progression, and limit new lesion formation on MRI. More than 20 distinct DMTs spanning injectable, oral, and infusion platforms are currently approved, each with unique mechanisms of action, adverse effect profiles, and monitoring requirements that non-prescribing rehabilitation and nursing professionals must understand to ensure safe, effective care. Network meta-analyses consistently demonstrate that high-efficacy therapies are superior in reducing annualized relapse rates compared to moderate-efficacy agents. Specifically, natalizumab, cladribine, and alemtuzumab each cut the proportion of patients experiencing relapses at 24 months by roughly 40 to 50% compared to placebo, representing large and clinically important reductions supported by high-certainty evidence. Moderate efficacy agents such as glatiramer acetate and interferon beta-1a provide more modest relapse reduction, each lowering relapse rates by approximately 16%, which is statistically significant but noticeably less robust than the high-efficacy therapies. Injectable DMTs include interferon beta-1a, interferon beta-1b, peginterferon beta-1a, and glatiramer acetate. Interferons exert immunomodulatory effects by shifting cytokine profiles from pro-inflammatory to anti-inflammatory and reducing T-cell migration across the blood-brain barrier. Common adverse effects include flu-like symptoms, injection site reactions, and rare hepatotoxicity, with monitoring requiring periodic liver function tests and complete blood counts. Glatiramer acetate induces regulatory T cells and is primarily associated with injection site reactions and transient post-injection systemic reactions, requiring patient education rather than extensive laboratory monitoring. Oral DMTs encompass several classes with distinct mechanisms and monitoring requirements. Sphingosine 1-phosphate receptor modulators, including fingolimod, siponimod, ozanimod, and ponesimod, sequester lymphocytes in lymph nodes, reducing CNS migration. First-dose cardiac effects require baseline electrocardiogram and cardiac monitoring for at least 6 hours after the initial dose, with ongoing ophthalmologic evaluation for macular edema at 1.6 to 2%, periodic liver function tests, and infection surveillance. Fumaretas, including dimethyl fumarate, diroximel fumarate, and monomethyl fumarate, activate the NRF2 pathway, a cellular defense mechanism that activates antioxidant and anti-inflammatory responses, and require regular complete blood counts to detect lymphopenia, which increases the risk of progressive multifocal leukoencephalopathy, or PML, a rare but serious opportunistic brain infection caused by the JC virus that can occur in immunosuppressed patients. Teriflunomide inhibits dihydroorotate dehydrogenase, a mitochondrial enzyme essential for pyrimidine synthesis in rapidly dividing lymphocytes, and requires liver function tests, blood pressure monitoring, and pregnancy testing due to teratogenicity. Cladribine, a purine analog, causes lymphocyte depletion and requires complete blood counts, tuberculosis screening, and cancer surveillance. Among infusion therapies, natalizumab blocks alpha-4 integrin on lymphocytes, preventing CNS entry. It's highly effective but carries significant PML risk, particularly in JC virus seropositive patients with prior immunosuppressant use. Monitoring includes JC virus serology every 6 months, regular MRI surveillance, and prompt escalation of any new neurological symptoms. Anti-CD20 monoclonal antibodies, including ocrelizumab, ofatumumab, and ublituximab, selectively deplete CD20-expressing B cells. Ocrelizumab is the only DMT approved for primary progressive MS. Adverse effects include infusion reactions, increased infection risk, and rare malignancy, with monitoring requiring baseline hepatitis B screening, periodic complete blood counts, immunoglobulin levels, and infection surveillance. Recent Canadian consensus recommendations support first-line use of high-efficacy agents in patients with aggressive disease phenotypes. Alemtuzumab targets CD52, causing profound lymphocyte depletion and requires extensive monitoring, monthly complete blood counts, thyroid function tests, renal function, and urinalysis for 48 months post-treatment due to risks of autoimmune thyroid disease at approximately 30 to 40%, immune thrombocytopenia, and nephropathy. The most significant recent pharmacologic development is the emergence of Bruton's tyrosine kinase inhibitors, or BTKIs, a new class of oral agents that block a key signaling enzyme in B cells and microglia. These include tolebrutinib, evobrutinib, and fenebrutinib. These oral agents target both B-cell signaling and CNS-resident microglia with reversible B-cell silencing and superior CNS penetration. In the Gemini Phase 3 trials, tolebrutinib demonstrated significant reductions in MRI lesion activity compared to teriflunomide, with liver enzyme elevations occurring at comparable rates in both treatment groups, at roughly 5% of patients in each arm, suggesting a manageable hepatic safety profile. BTK inhibitors address compartmentalized inflammation driving progression and may promote myelin repair mechanisms, representing a potential shift in how we approach progressive MS treatment. The standard first-line treatment for moderate to severe MS relapses is high-dose corticosteroids. The typical regimen is intravenous methylprednisolone, 500 to 1,000 mg daily for 3 to 5 days, with oral prednisone at equivalent doses as a non-inferior alternative. Corticosteroids accelerate symptom recovery, but don't alter the long-term disease course or prevent future relapses. Mild relapses that don't impair function may be observed without treatment, as spontaneous recovery is possible. Adverse effects include hyperglycemia, hypertension, mood disturbances, insomnia, gastrointestinal irritation, and increased infection risk, requiring monitoring of blood pressure, blood glucose, and mental status. For severe relapses unresponsive to corticosteroids, plasma exchange, or PLEX is recommended as second-line therapy. Meta-analyses report overall clinical response rates of approximately 76 to 80%. The typical protocol involves 5 to 7 exchanges over 2 weeks, with each session removing plasma and replacing it with albumin or saline. A retrospective study of 145 patients demonstrated that PLEX was clearly superior to escalated methylprednisolone, with good or average recovery at discharge in 93.5% of PLEX patients versus 29.3% of escalated steroid patients. That's a striking difference. Adverse effects of PLEX include hypertension, bleeding, infection, allergic reactions, and electrolyte disturbances. Immunoadsorption is a comparable alternative for patients who are intolerant of PLEX. Spasticity affects up to 80% of MS patients and is managed with a stepwise pharmacologic approach. First-line oral agents are baclofen, a GABA B agonist starting at 5 mg 3 times daily and titrated up to 80 mg per day, and tizanidine, an alpha-2 adrenergic agonist starting at 2 mg and titrated up to 36 mg per day. Both cause sedation and weakness. Tizanidine additionally requires liver function test monitoring due to hepatotoxicity risk. For refractory spasticity, intrathecal baclofen, intramuscular botulinum toxin, and nabiximols oromucosal spray with a 1:1 THC to CBD ratio are recommended. The American Academy of Neurology notes that oral cannabis extract may improve subjective spasticity symptoms, but is probably ineffective for objective spasticity measures. Neuropathic pain is managed with tricyclic antidepressants such as amitriptyline 10 to 75 mg at bedtime, serotonin norepinephrine reuptake inhibitors such as duloxetine 30 to 60 mg daily, and anticonvulsants such as gabapentin 300 to 3,600 mg per day, and pregabalin 75 to 600 mg per day. Trigeminal neuralgia is treated with carbamazepine 200 to 1,200 mg per day, or oxcarbazepine, requiring monitoring of complete blood counts and serum sodium. Bladder dysfunction, typically detrusor overactivity, is treated first-line with antimuscarinic agents, though anticholinergic burden limits use in cognitively impaired patients. Mirabegron offers fewer anticholinergic effects, but requires blood pressure monitoring, and onabotulinum toxin A at 100 to 200 units intravesically is available for refractory neurogenic detrusor overactivity. Regarding fatigue pharmacotherapy, a landmark randomized placebo-controlled crossover trial of 141 participants found that amantadine at up to 100 mg twice daily, modafinil at up to 100 mg twice daily, and methylphenidate at up to 10 mg twice daily were not superior to placebo on the Modified Fatigue Impact Scale and caused more frequent adverse events at 39 to 40% compared to 31% with placebo. No medication is FDA approved for MS fatigue, and non-pharmacologic interventions, including exercise, cognitive behavioral therapy, and energy conservation strategies, have stronger evidence and should be prioritized. DMT selection and treatment transitions significantly impact rehabilitation planning and functional outcomes. Early intensive treatment with high-efficacy DMTs produces superior disability outcomes compared to escalation strategies. A population-based cohort study found that patients receiving early intensive treatment had far less disability accumulation over 5 years, with a mean EDSS change of just 0.3 compared to 1.2 in the escalation group. The median time to sustained disability accumulation was also nearly twice as long in the early intensive group, at 6.0 years versus 3.1 years. Here's the concerning part. 60% of patients in the escalation group developed sustained disability while still on moderate efficacy treatment before escalation occurred. That suggests current surveillance strategies may be insufficiently responsive. Long-term DMT exposure reduces disability accrual in a dose-dependent manner, with continuous treatment over 15 years reducing disability worsening by 19 to 44%, reducing the risk of requiring a walking aid by 67%, and decreasing relapse frequency by 40 to 41%. Very early treatment initiation, within 6 months of the first demyelinating event, substantially reduces the risk of reaching important disability milestones, cutting the risk of reaching EDSS 3.0 by roughly 45%, cutting the risk of secondary progressive MS by roughly 60%, and cutting the risk of sustained disease progression at 12 months by roughly 50%, all compared to delayed treatment initiation. DMTs also reduce progression independent of relapse activity, which accounts for a substantial proportion of disability accumulation in treated patients. Post-hoc analyses demonstrate that ocrelizumab and ofatumumab are superior to interferon beta-1a or teriflunomide in preventing both relapse-associated worsening and PIRA. This emerging understanding of PIRA reinforces the rationale for early high-efficacy treatment to optimize long-term functional trajectories. DMT-related adverse effects directly impact rehabilitation tolerance and therapy participation. All DMTs carry infection risks due to immune system modulation, with rates varying from 8.9 per 1,000 person-years for injectables to 19.7 for rituximab. S1P modulators cause first-dose bradycardia at 0.5 to 4% and heart block at 1.2 to 3%, requiring cardiac monitoring that may delay rehabilitation initiation. Fumarate and teriflunomide are associated with gastrointestinal symptoms and hepatotoxicity that may limit exercise tolerance. Alemtuzumab causes secondary autoimmune thyroid disease, hypertension, and cardiovascular disease, requiring ongoing monitoring. Treatment discontinuation due to adverse events occurs more frequently with fingolimod, teriflunomide, and natalizumab compared to placebo. Rehabilitation professionals should recognize that DMT efficacy and tolerability directly influence rehabilitation capacity and outcomes. This includes timing rehabilitation intensity around DMT initiation and transitions, implementing infection prevention strategies during rehabilitation for patients on immunosuppressive therapies, recognizing adverse effects that may mimic MS symptoms versus true disease progression, and coordinating with prescribers when adverse effects limit rehabilitation participation. All members of the rehabilitation and nursing team share responsibility for recognizing potential DMT adverse effects, as early identification and communication to the prescribing team can prevent serious complications and optimize rehabilitation outcomes. AAN guidelines suggest considering DMT switching when patients experience 1 or more relapses, 2 or more new MRI lesions, or increased disability over 1 year despite adequate treatment. Vertical switches from moderate to high-efficacy DMT are indicated for breakthrough disease activity, while horizontal switches address tolerability concerns. Critical considerations during transitions include washout periods, which is the time required after stopping one DMT before starting another, carryover PML risk, and potential rebound disease activity, a surge in inflammatory activity that can occur after discontinuation of certain DMTs, particularly natalizumab and S1P modulators. All of these may temporarily limit rehabilitation intensity. Nursing professionals play critical roles in DMT management, serving as essential links between neurology teams, patients, and rehabilitation services. Depending on jurisdictional scope of practice, nurses may administer monoclonal antibody infusions and manage infusion-related reactions, which occur in 24% of natalizumab patients, 34 to 40% with ocrelizumab, and 92% with alemtuzumab. For S1P receptor modulators, nurses conduct first-dose observation protocols, monitoring all patients for at least 6 hours with hourly pulse and blood pressure assessments. Nurses typically coordinate laboratory monitoring tailored to each DMT, including monthly complete blood counts for alemtuzumab, quarterly liver function tests for teriflunomide, and periodic immunoglobulin levels for anti-CD20 therapies. They must also recognize PML symptoms, which include progressive weakness, vision changes, impaired memory, confusion, and personality changes developing over days to weeks. MRI lesions can develop months before PML symptoms become clinically apparent, and asymptomatic detection significantly improves outcomes with reduced disability and mortality compared to symptomatic diagnosis. Risk stratification guides surveillance intensity, with patients on natalizumab with JC virus antibody index and risk greater than 0.9 per 1,000, requiring intensive monitoring with more frequent MRI assessments. Nurses should maintain heightened PML awareness for patients receiving natalizumab, fingolimod, dimethyl fumarate, and cladribine. Nurses also support infection prevention strategies, including ensuring varicella-zoster virus vaccination before starting S1P modulators, screening for hepatitis B before initiating anti-CD20 therapies, and tuberculosis screening before alemtuzumab and cladribine. Adherence rates to DMTs range from 52 to 92.8%, with poor adherence reducing clinical effectiveness and increasing MS-related hospitalizations. Key factors affecting adherence include age, gender, depression, cognition, treatment satisfaction, injection site reactions, and injection anxiety. Nurses enhance adherence through individualized education about safety profiles and realistic expectations, regular interactions to identify and treat adverse effects promptly, and addressing injection anxiety. Higher quality of life in activities of daily living and relationship with the healthcare system correlates with better adherence. Shared decision-making, incorporating patient-reported outcome measures and decision aids, is increasingly recognized as essential for optimizing treatment engagement, with attention to cognitive dysfunction and fatigue that may affect understanding. MS care units represent the optimal model for thorough care, with MS neurologists and nurses forming the core team working with formalized protocols for DMT initiation and follow-up. Moving on to Module 7, Multidisciplinary Care, Psychosocial Impact, and Health Equity. Effective MS management extends beyond individual interventions to the systems and teams that deliver care. The thorough care of adults with multiple sclerosis requires a coordinated, multidisciplinary team structured to address the varied and evolving physical, cognitive, psychosocial, and social needs of this population. The core team typically includes neurologists, Mississippi, specialized nurses, physical therapists, occupational therapists, speech-language pathologists, neuropsychologists, and social workers, with additional involvement from primary care physicians, urologists, pharmacists, psychologists, and dietitians as clinically indicated. The MS Care Unit model, proposed by Solberg Sorensen and colleagues, co-locates these disciplines within a centralized clinic to enable seamless care coordination, reduce wait times, and let each professional focus on their area of expertise. Despite this ideal, surveys of Canadian MS clinics reveal that more than 50% report wait times exceeding 3 months for physiatrists, physiotherapists, psychiatrists, psychologists, neuropsychologists, and urologists. And 69.6% of clinics indicate insufficient non-neurologist providers to deliver adequate care. Physical therapists are responsible for assessment and management of mobility, balance, strength, spasticity, and gait disturbances, though scope of practice may vary by jurisdiction and practice setting. The American Academy of Neurology Systematic Review found that weekly home or outpatient physical therapy over 8 weeks probably improves balance, disability, and gait in patients able to walk at least 5 meters, representing Class 1 evidence. 6 weeks of thorough multidisciplinary outpatient rehabilitation possibly improves disability and function in progressive MS with EDSS, 4.0 to 8.0, representing Class 2 evidence. Occupational therapists optimize independence in activities of daily living, instrumental activities of daily living, work participation, and sleep, and provide training in energy conservation, task modification, and compensatory strategies. The American Occupational Therapy Association practice guidelines recommend OT interventions for improving participation in activities of daily living, sleep, and work, and for supporting caregivers. MS nurses serve as the primary point of contact for patients, coordinate care across settings, manage disease-modifying therapy adherence and side effects, triage acute issues, and provide self-management education. Neuropsychologists evaluate and manage cognitive dysfunction, which affects 40 to 80% of people with MS, as well as mood disorders and behavioral changes. They develop compensatory strategies and psychological interventions. Social workers address social determinants of health, help patients access community resources and disability benefits, provide counseling, and support long-term care planning. Across all disciplines, core interprofessional competencies for MS care include recognizing signs of disease progression versus treatment side effects, communicating assessment findings to the neurology team, supporting patient self-management and treatment adherence, and coordinating care transitions across settings. The Cochrane Overview by Amatya and colleagues synthesized 15 reviews encompassing 164 randomized controlled trials and 10,396 participants, concluding that moderate quality evidence supports structured, multidisciplinary rehabilitation programs for producing longer-term gains in activity, participation, mobility, muscle strength, aerobic capacity, and quality of life. Despite this consensus, no large randomized trials have fully evaluated the impact of multidisciplinary care on MS outcomes, and the evidence base relies heavily on observational data and expert consensus. Care coordination across inpatient to outpatient and outpatient to home transitions is essential for adults with MS. The COCOS-MS randomized Phase 2 trial evaluated a cross-sectoral care and case management intervention for adults with severe MS over 12 months. While the primary endpoint of quality of life didn't reach statistical significance, secondary outcomes demonstrated clear benefits in psychological distress and palliative care needs during the intervention period. Qualitative analysis revealed that patients, caregivers, and healthcare specialists valued the case manager as a continuous, objective contact person and a competent source of information, with 852 coded segments reflecting relief and support across health-related, social, financial, and bureaucratic domains. Telerehabilitation has emerged as a clinically effective and feasible modality for delivering rehabilitation services to adults with MS. A systematic review comparing telerehabilitation with traditional rehabilitation found that telerehabilitation achieved more positive effects on physical and cognitive outcomes, particularly when delivered synchronously and in the home setting. Meta-analyses demonstrate significant effects on both mobility and balance, with feasibility exceeding 90%. Remote monitoring technologies, including wearable sensors, smartphone-based assessments, and digital patient-reported outcome platforms, enable continuous, real-time tracking of motor and non-motor symptoms. Telehealth visits reduce missed workdays and costs for patients, with high satisfaction reported by both patients and providers, although disparities in access to digital health platforms persist among patients with lower income, limited digital literacy, or inadequate broadband access. Patient education is a foundational component of thorough MS care, and information provision interventions consistently increase disease-related knowledge across diverse delivery formats. Multi-component self-management interventions with multimodal delivery methods and cognitive behavioral theory principles represent common elements of effective programs that improve quality of life. A systematic review and meta-analysis of lifestyle self-management regimens found that programs incorporating exercise, stress management, dietary modification, and psychoeducation improve overall quality of life in people with MS. Shared decision-making is a critical element of MS care for all members of the healthcare team, given the preference-sensitive nature of many treatment decisions and the increasing number of disease-modifying therapies available. Key elements for effective shared decision-making include communication training for professionals, feedback on performance, encouraging patient participation, providing balanced evidence-based information about benefits and harms of different options, and systematic use of patient-reported outcome measures. Several patient decision aids have been developed following international patient decision aid standards, incorporating multi-criteria decision analysis to reduce cognitive burden when considering treatment options. Shared decision-making is particularly important in MS because cognitive dysfunction and fatigue may affect information processing, requiring clinicians to attend to information dosage and format. Health literacy is an important determinant of self-management capacity and clinical outcomes in MS. A meta-analysis across chronic diseases found a moderate positive association between health literacy and self-care, showing the importance of ensuring that educational materials are accessible across literacy levels. Higher digital health literacy is consistently associated with improved patient behaviors, enhanced self-management including better medication adherence, and improved telehealth engagement. However, disparities remain entrenched, with older adults, rural populations, and individuals with lower incomes facing greater barriers to effective telehealth engagement. Lower health literacy has been reported in low-income Black and Hispanic or Latinx patients with MS compared to white patients, and illness perceptions, including cultural beliefs about disease causation, vary significantly across racial and ethnic groups, influencing treatment decisions and adherence. Supporting healthcare systems to provide clinicians with training in cultural humility and cross-cultural communication can reduce implicit bias and administrative and linguistic barriers while improving health literacy. As discussed in Module 3, depression and anxiety occur at rates far exceeding those in the general population among adults with MS, with lifetime major depressive disorder, prevalence of 36 to 54%, and anxiety affecting approximately 35.7%. Beyond these prevalence figures, a large-scale UK MS Register survey of 4,178 respondents found that 54.1% scored at or above the clinical threshold for anxiety and 46.9% for depression on the Hospital Anxiety and Depression Scale. In the first year after MS diagnosis, approximately 47.4% of newly diagnosed patients experience clinically significant depression and 38.7% experience anxiety, with high rates of symptom co-occurrence. A large Iranian cross-sectional study of 4,460 MS patients found higher rates of major depressive disorder in progressive MS subtypes at 16.2% in progressive versus 11.5% in relapsing remitting MS. Symptoms of depression and anxiety are early predictors of multi-domain disability progression in progressive MS, further reinforcing the clinical significance of these comorbidities. Psychosocial well-being is a key modifiable determinant of treatment adherence. A prospective study demonstrated that MS patients with current mood or anxiety disorders were nearly 5 times as likely to exhibit poor adherence to disease-modifying therapies compared with those without psychiatric diagnoses, with poor adherence also associated with memory difficulties, neuroticism, and low conscientiousness. Depression and anxiety are significantly correlated with lower medication adherence, while higher acceptance of illness is associated with better adherence. A systematic review identified depression, anxiety, cognitive impairment, and treatment satisfaction as the most prevalent psychosocial factors associated with adherence, noting that poor adherence is linked to increased disease progression, hospitalizations, and mortality. Higher quality of life in domains related to activities of daily living and relationships with the healthcare system is also associated with better adherence. These findings make clear that addressing emotional distress, promoting illness acceptance, and strengthening the patient-provider relationship are essential strategies for optimizing treatment adherence. Caregiver burden among informal caregivers of adults with MS is consistently high. A Polish cross-sectional study found that 70.9% of caregivers reported psychological fatigue and 60.2% physical fatigue. Depression in patients with MS directly increases caregiver strain, with neuropsychiatric symptoms, including depression, cognitive impairment, and apathy, strongly associated with increased caregiver distress, independent of physical disability. Caregivers need to reconcile working times with care times, have space for self-care, and opportunities to share experiences with others. Peer support is desired but underused among MS caregivers, with barriers including lack of promotion and awareness. Among people with MS themselves, peer support engagement is associated with greater social support and reduced loneliness. Compassion-focused group therapy programs for caregivers are under evaluation. Cognitive behavioral therapy is the most extensively studied non-pharmacological intervention for depression and adjustment in MS. A thorough systematic review and network meta-analysis of 111 studies found that CBT was most effective overall and that psychological therapies significantly improved mental health, physical health, quality of life, and cognition. The AAN specifically recommends telephone-administered CBT as a possibly effective treatment for depressive symptoms in MS. Routine screening with validated tools such as the Patient Health Questionnaire 9 or PHQ-9, a 9-item self-report depression screening tool scored 0 to 27, which demonstrates excellent sensitivity and high specificity at a cut point of 11, reliably distinguishing MS patients with and without major depression. And the Beck Depression Inventory, followed by stepped care interventions, represents a feasible and evidence-based approach for non-specialist clinicians. Unemployment rates among MS patients are high, with pooled estimates suggesting approximately 35.6% unemployment across studies and only 45 to 61% of patients remaining employed after disease onset. Key predictors of workforce exit include progressive MS, lower education level, higher disability, fatigue, cognitive impairment, and pain. Vocational rehabilitation services demonstrate feasibility when delivered through multidisciplinary teams, and workplace accommodations, most frequently flexible hours, are essential for job retention. Employment positively impacts psychological well-being and quality of life, with employed MS patients reporting significantly greater quality of life, fewer MS-related difficulties, and more effective problem-focused coping strategies compared to unemployed peers. Substantial evidence demonstrates that disparities in access, outcomes, and equity for MS care are pervasive and driven by intersecting social, economic, geographic, and systemic factors. Black, Hispanic, or Latinx, and Indigenous individuals with MS in the United States experience increased morbidity, earlier and more severe disability accumulation, and higher mortality compared to white individuals. These disparities are strongly influenced by social determinants of health, including lower income, reduced educational attainment, and systemic racism. Geographic disparities are a major contributor to inequitable access, with rural and micropolitan areas having markedly reduced access to neurologists and MS specialty centers. Cost-related non-adherence to disease-modifying therapy is more prevalent among racial and ethnic minorities, those with lower income, and individuals with higher disability. Telehealth and remote monitoring have the potential to reduce some access barriers, but disparities in access to digital health platforms persist. Patients with higher income, greater familiarity with technology, and those living farther from specialty centers are more likely to use and benefit from telemedicine, while those with lower income or digital literacy may be excluded. The MS 360-degree conceptual framework proposes a digital-first, data-driven hybrid care model for personalized MS management, integrating clinical, radiological, biomarker, and patient-reported data in a structured and individualized manner. Addressing these inequities requires expanding the geographic distribution of neurologists and MS centers, increasing workforce diversity, standardizing imaging and treatment protocols, implementing patient navigation and community outreach programs, and investing in digital literacy and infrastructure in underserved communities. Clinicians should routinely assess social determinants of health, including income, education, employment, cultural beliefs, and social support networks as part of thorough MS care. Interventions should be tailored to the sociocultural context of each patient, with attention to language, health literacy, and cultural norms. Without concerted efforts to address structural, geographic, and digital barriers, advances in MS care risk perpetuating or widening existing disparities. We now arrive at Module 8, Case Studies. The following case studies illustrate how the concepts, assessment tools, and interventions covered throughout this course are integrated in clinical practice. Let's begin with Case Study 1, Early Relapsing Remitting MS, focusing on assessment and rehabilitation planning. Maria is a 29-year-old Latina woman and elementary school teacher who presents to the outpatient neurology clinic 3 weeks after her initial MS diagnosis. She was diagnosed with relapsing remitting MS following 2 clinical episodes, an episode of optic neuritis in her left eye 8 months ago that resolved with corticosteroids, and a more recent episode of right-sided numbness and tingling in her hand and foot lasting 3 weeks. MRI demonstrated multiple periventricular and juxtacortical lesions, fulfilling the 2017 McDonald criteria for dissemination in space and time. Cerebrospinal fluid analysis revealed the presence of oligoclonal bands. Her expanded disability status scale score is 1.5, and serum neurofilament light chain levels are mildly elevated. The rehabilitation team selects standardized assessment tools appropriate for Maria's low disability level. The timed 25-foot walk is administered as a baseline measure of ambulation speed, yielding a time of 4.8 seconds within normal limits. The symbol-digit modalities test is administered as a cognitive screen, given that cognitive impairment affects 40 to 80% of people with MS and may be present even early in the disease course. Maria scores 52, mildly below age-adjusted norms, suggesting subtle processing speed deficits warranting longitudinal monitoring. The modified fatigue impact scale reveals a total score of 38 at the high impact threshold for fatigue on her daily activities. The PHQ-9 is administered as a depression screen, yielding a score of 7, below the recommended cut point of 11 for major depressive disorder in MS, but warranting continued surveillance. Maria's neurologist initiates a disease-modifying therapy, and the rehabilitation team develops an individualized exercise prescription following National Multiple Sclerosis Society and Exercise and Sports Science Australia guidelines. Moderate intensity aerobic exercise at 60 to 80% of age-predicted maximum heart rate for 30 minutes at least twice weekly, plus progressive resistance training 2 to 3 times per week. Heat sensitivity management strategies are discussed, including exercising in air-conditioned environments, wearing cooling garments, and hydrating adequately. Shared decision-making principles are applied in therapy selection, with balanced information about treatment benefits and risks provided using decision aids appropriate to Maria's health literacy level. Given Maria's cultural background, the clinician explores her illness perceptions and ensures educational materials are available in Spanish, consistent with culturally responsive education approaches. The team schedules follow-up assessments at 3 and 6 months to monitor cognitive function, fatigue trajectories, and functional status. Case Study 2 focuses on progressive MS and managing invisible symptoms. David is a 52-year-old African-American man and retired firefighter who is referred to the MS Rehabilitation Clinic with a 15-year history of MS, now classified as secondary progressive MS. He reports worsening fatigue that prevents him from completing household tasks, increasing difficulty with memory and concentration, and persistent low mood over the past 6 months. His wife reports that he's become increasingly withdrawn and irritable. His EDSS score is 5.5, and he ambulates with a single-point cane. He's been on a disease-modifying therapy for 8 years. The rehabilitation team conducts a multidimensional assessment. The Modified Fatigue Impact Scale, total score is 62, indicating severe fatigue. The symbol-digit modalities test score is 38, consistent with moderate cognitive impairment and a decline from his score of 48 2 years prior, placing him in a pattern consistent with the cognitive staging model for MS. The PHQ-9 score is 14, exceeding the cut point of 11 and prompting referral for further diagnostic evaluation for major depressive disorder. The Berg Balance Scale score is 42, indicating moderate full risk. Symptoms of depression and anxiety in David's case are clinically significant, as recent evidence demonstrates they're early predictors of multi-domain disability progression in progressive MS. The team implements a stepped care approach. For fatigue, the Facets program model is applied, incorporating cognitive behavioral techniques, energy conservation, and pacing strategies. Cognitive rehabilitation follows the modified story memory technique, an evidence-based approach for learning and memory deficits in MS. David is referred for cognitive behavioral therapy targeting depressive symptoms, consistent with the AAN recommendation for telephone-administered CBT as a possibly effective treatment, and an internet-delivered CBT program is offered as an accessible alternative given his mobility limitations. The caregiver burden on David's wife is assessed, revealing significant psychological fatigue, and she is connected with a caregiver peer support program. The team coordinates with David's neurologist regarding potential DMT transition, given evidence of ongoing progression. While David's case highlights invisible symptom management, Case Study 3 focuses on full risk and spasticity management. Ingrid is a 61-year-old white woman and retired nurse who presents to the rehabilitation clinic with a primary progressive MS diagnosis of 10 years duration. She reports 2 falls in the past month, both occurring during transfers. She describes bilateral lower extremity stiffness that worsens in the evenings and disrupts her sleep. Her EDSS score is 6.0, and she uses a rollator walker for community ambulation. She lives alone in a single-story home. The clinician administers the Berg Balance Scale, on which Ingrid scores 36, below the full risk cutoff of 50.5 and consistent with high full risk in MS. The mini best test is also administered to evaluate anticipatory postural adjustments, reactive postural control, sensory orientation, and dynamic gait, yielding a score of 14 out of 28. Spasticity in bilateral hip adductors and ankle plantar flexors is assessed using both the modified Ashworth scale and the Tardieu scale, with mass scores of 2 in hip adductors and 3 in ankle plantar flexors, bilaterally. The timed 25-foot walk is 12.3 seconds, indicating significant gait impairment well above normative values, where exceeding 6 seconds indicates clinically meaningful slowing. A multimodal spasticity management plan is developed integrating pharmacologic and non-pharmacologic approaches. The clinician implements a progressive balance training program incorporating dual-task training and task-specific exercises, consistent with evidence supporting balance and gait interventions for fall prevention in MS. Stretching, positioning, and strengthening exercises target the spastic muscle groups, supplemented by referral to the neurologist for review of anti-spasticity medication. A home safety assessment is completed, and environmental modifications including grab bars and improved lighting are recommended. The team discusses the potential role of aquatic therapy, which provides a buoyancy-assisted environment for movement and has demonstrated benefits for balance and spasticity in MS. Follow-up assessments are scheduled at 8 and 16 weeks, with clinically meaningful change thresholds for the Berg Balance Scale at 7 points and timed 25-foot walk at 20% guiding outcome evaluation. The final case study brings together multiple dimensions of MS care, including medical management, rehabilitation, psychosocial support, and vocational planning in a patient navigating disease transition. Case Study 4 focuses on multidisciplinary care coordination and self-management. James is a 44-year-old man and software engineer who was diagnosed with relapsing remitting MS 6 years ago and has recently been reclassified as secondary progressive MS based on gradual worsening over the past 18 months independent of relapses. He continues to work full-time but reports increasing difficulty with cognitive demands at work, persistent fatigue limiting his productivity, and anxiety about his future employment. He's married with 2 school-aged children. His EDSS score is 4.0, and he ambulates independently, but notes declining walking endurance. The multidisciplinary team conducts a thorough evaluation. The 6-minute walk test distance is 380 meters, below the normative threshold, and representing a 70-meter decline, or 15.6% from 450 meters 1 year prior. That substantially exceeds the 21.6-meter minimal important change threshold and indicates clinically meaningful deterioration in walking endurance. The 9-hole peg test reveals mild bilateral upper extremity slowing, with dominant hand at 22.5 seconds and non-dominant at 25.1 seconds. The symbol-digit modalities test score is 42, indicating mild cognitive slowing. The modified fatigue impact scale score is 54, indicating moderate to severe fatigue. The generalized anxiety disorder 7-item scale score is 12, suggesting moderate anxiety. Treatment adherence to his current disease-modifying therapy is reviewed, and James reports occasionally missing doses due to fatigue and forgetfulness, consistent with evidence that fatigue and cognitive impairment are significant predictors of non-adherence. The team implements a coordinated multidisciplinary care plan, aligned with the MS Care unit model. The neurologist discusses DMT transition options using shared decision-making principles, incorporating patient decision aids to compare efficacy, safety, and convenience profiles of available therapies. The rehabilitation team addresses workplace accommodations, recommending flexible scheduling, structured rest breaks, and assistive technology for cognitive demands, consistent with evidence that vocational rehabilitation services and workplace modifications are essential for job retention in MS. The occupational therapist develops an individualized fatigue management program integrating energy conservation strategies, pacing techniques, and structured physical activity. Cognitive rehabilitation targeting processing speed and working memory is initiated using the modified story memory technique, with the goal of maintaining vocational capacity. A referral is placed for psychological support addressing James's anxiety, and the team ensures his wife has access to caregiver resources. The rehabilitation plan includes adherence support strategies, such as simplified dosing reminders and regular follow-up contacts, with reassessment at 3-month intervals using the 6-minute walk test, SDMT, and MFIS to track functional trajectories and guide treatment adjustments. This integrated approach shows how coordinated, multidisciplinary care can address the complex intersection of physical, cognitive, psychosocial, and vocational needs in adults with MS. Thank you for completing this course. We will now review the exam questions to solidify your understanding. Question 1. What is the strongest environmental risk factor identified for developing multiple sclerosis? The correct answer is C. Epstein-Barr virus infection. Rationale. The course identifies Epstein-Barr virus as the dominant infectious risk factor for MS. A landmark prospective study in United States military personnel demonstrated that the risk of developing MS after EBV seroconversion was more than 30 times higher than in those who remained seronegative, making it one of the strongest environmental associations identified for any autoimmune disease. Question 2. Which cognitive domain is most frequently impaired in adults with multiple sclerosis? The correct answer is A. Information processing speed. Rationale. The course identifies information processing speed as the most frequently affected domain in MS-related cognitive impairment, with impairment rates of 27 to 51%. Isolated information processing speed impairment is a strong predictor of further cognitive decline, with 69% of patients progressing over 5 years. Question 3. Which immune cells have emerged as pivotal players in MS pathogenesis, contributing through antigen presentation, pro-inflammatory cytokine secretion, and intrathecal immunoglobulin production? The correct answer is A. B cells. Rationale. The course states that B cells have emerged as key players in MS pathogenesis, as shown by the dramatic efficacy of anti-CD20 monoclonal antibodies in reducing disease activity. B cells contribute through antigen presentation to T cells, secretion of pro-inflammatory cytokines, and production of intrathecal immunoglobulins. Question 4. A rehabilitation professional is developing an initial physical activity plan for a newly diagnosed patient with MS who has been sedentary. According to National MS Society guidelines, what is the minimum weekly exercise recommendation for all individuals with multiple sclerosis? The correct answer is A. At least 150 minutes per week of exercise or lifestyle physical activity. Rationale. The course states that the National MS Society, in collaboration with the Consortium of Multiple Sclerosis Centers, recommends that all individuals with multiple sclerosis engage in at least 150 minutes per week of exercise and/or lifestyle physical activity, with gradual progression based on abilities, preferences, and safety. Question 5. Approximately what percentage of MS patients initially present with the relapsing remitting phenotype? The correct answer is D. 85 to 90%. Rationale. The course states that relapsing remitting MS is the most common initial phenotype, accounting for approximately 85 to 90% of cases at onset. It typically affects young adults with a mean age at onset of 30 years and a 3-to-1 female predominance. Question 6. Which balance assessment tool is recommended for ambulatory MS patients with mild to moderate disability due to its low ceiling effect and high responsiveness to change following rehabilitation? The correct answer is D. Mini Balance Evaluation Systems Test, Mini-BEST test. Rationale. The course states that the Mini Balance Evaluation Systems test demonstrates superior measurement properties for ambulatory MS patients compared to the BBS, with a markedly lower ceiling effect, no patients hitting the maximum score compared to 38.5% for the BBS, and nearly twice the responsiveness to change following rehabilitation. Question 7. A patient with relapsing remitting MS has experienced no clinical relapses over 3 years, yet their neurologist documents gradual worsening on the expanded disability status scale. What proportion of disability accrual events does progression independent of relapse activity, PIRA, account for in typical relapsing remitting MS? The correct answer is B, at least 50%. Rationale. The course states that PIRA accounts for at least 50% of disability accrual events, even in typical RRMS, with this proportion increasing with disease duration and age. Early PIRA is associated with a dramatically elevated risk of reaching EDSS 6.0, making it the strongest predictor of long-term disability in MS. Question 8. Which cognitive screening tool is recommended by the National MS Society and the Consortium of Multiple Sclerosis Centers as the minimum bedside cognitive assessment for individuals with MS? The correct answer is C. Simple Digit Modalities Test, SDMT. Rationale. The course states that the National MS Society, the Consortium of Multiple Sclerosis Centers, and the International Multiple Sclerosis Cognition Society recommend the SDMT as the minimum bedside cognitive screening tool, with baseline testing soon after diagnosis and annual reassessment. Question 9. A patient with MS who recently transitioned to natalizumab, a high-efficacy disease-modifying therapy associated with progressive multifocal leukoencephalopathy risk, presents for a routine nursing visit. Which of the following best describes a primary nursing responsibility in the ongoing management of this patient's disease-modifying therapy? The correct answer is C. Coordinating laboratory monitoring and recognizing symptoms of progressive multifocal leukoencephalopathy, PML. Rationale. The course describes nursing professionals as coordinating laboratory monitoring tailored to each DMT and states they must also recognize PML symptoms, which include progressive weakness, vision changes, impaired memory, confusion, and personality changes developing over days to weeks. Question 10. Which non-pharmacologic intervention is identified as the first-line treatment for MS-related fatigue, with effects maintained at 24-week follow-up? The correct answer is B. Cognitive behavioral therapy, CBT. Rationale. The course states that cognitive behavioral therapy, or CBT, is a first-line non-pharmacologic intervention for MS-related fatigue. The Combo MS trial demonstrated that CBT produced clinically meaningful reductions in fatigue impact, with effects maintained at 24-week follow-up. Thank you for completing this exam review. We hope this course has strengthened your understanding of multiple sclerosis and equipped you with current, evidence-based knowledge to support your clinical practice. Best wishes in your continued professional development.